Good morning, everybody. Bwrdd Dda and croeso. Okay, and a very warm welcome to our live broadcast board meeting. And we've got a lot to consider today, as usual, on our agenda. So I'm going to go straight to the agenda. First of all, if I could have apologies.
Yes, Chair, we've got apologies from Jonathan Griffiths, Associate Member for Local Authorities.
Thank you. And any declarations of interest? Okay, thank you. If we could go to the minutes of the public meeting held on the 28th of January. Are there any inaccuracies within the minutes? Okay, thank you. The board's happy to approve them as a true record. Diolch. Then we go to the matters arising. PM 2108 is to provide an update on discussions around the KPMG review and partnership governance arrangements. Is this still ongoing?
Yes, Chair, unfortunately the meeting was cancelled on the 22nd of March, but we have been doing work in the background with colleagues in the local authority and within governance, so that will be rescheduled at Easter, and Judy's going to kindly chair that meeting as the chair of the RPB.
Okay, thank you. So it will come back to our next meeting.
Yes,
thank you. And then the last PM 2115, the performance update, to discuss with the Vice Chair the comparative data regarding mental health and to share with the Vice Chair updates on the position with regards to waiting lists. The first one, the meeting is to be scheduled. Is that taking place?
Chair, many thanks. Yes, we've had a meeting and I'll provide the Vice Chair with a briefing as a result of that meeting. We had the meeting last week. Thank you.
Okay, so we can say that that has been completed now. Thank you very much. Thanks, everybody. If we go on to my report next, I'll take it as we all do that. All these papers have been read. It's been a year, as we all know, since lockdown, and a year where everyone has pulled together and all our staff and their families have made tremendous sacrifices and given everything of themselves. And I think this week was a very emotional and poignant week when we stopped together and reflected. We're incredibly proud and grateful to everybody. I'd like to draw your attention in my report to some of the voices of our staff, and I'm really glad that we are doing a discovery report to dig even deeper into our organisation to hear staff's experiences and their views. And key messages that I've heard and others have heard in our organisation are the need to be listened to, the need to be recognised, the need to remember, to rest and to recuperate. So we've set up a rest and recovery reference group as detailed in my report to continue and to build on the support that we've already have been given throughout the year, and to listen to staff so that we can work together to increase that support. So I'd like to thank everybody on the group who is contributing, and I'm really pleased to see some external experts from the military, from other organisations and from the tourist industry. I'd also like to draw attention to the wards set out in my report. Often when there's a long list, we may not read it, but each and every person on that list has so deserved their awards, and it was great to meet many of them and listen to them. And I'd also like to draw attention to the closure of Penally Army Camp, and I'd like to thank Jill and Ros and Steve and Phil and all the teams for doing everything possible to support the health and well-being of the men who were placed in the camp during the middle of the pandemic, and for continuing to support the surrounding community. And I'm sadly also going to thank 3 of our valued independent members who are stepping down. This is their last board meeting, and it's after many years of dedicated service. So that's Councillor Simon Hancock, Owen Bear and Mike Lewis. And I'd like to personally thank you, the 3 of you, for your tremendous support and service during the last year in this pandemic. And at the same time, I'd like to announce that the Minister has appointed 3 new independent members, Winston Weir, Councillor Gareth John and Ewan Thomas, and has reappointed Delith Rainsford as an independent member. So I'm very happy to take any questions or comments on my report? If you could raise your hands, or Simon, please come in, and then Judith.
Thank you very much, Chair. Can I ask a question and also a comment, please? You mentioned about the closure of the Penally Army Camp, which was announced for the 21st of March. Obviously, the asylum seekers should never have been put in such manifestly unsuitable accommodation, and the whole thing really was done in a very, very poor way indeed. You've rightly responded to the excellent response of all our staff, but can I ask whether there's been any recompense for the financial costs? I know that Pembrokeshire County Council have invoiced the Home Office for £80,000 in respect of their costs, and Dyfed Powys Police Force are out of pocket to the tune of £685,000. So I just wondered what our costs were, and are we going to see those reimbursed by central government? That's the question on the Penally Army Camp. And if you would allow me, Chair, to make a comment. Thank you very much indeed for those very kind comments. This is my last board meeting after my just over 7 years service, and can I just say it's been an immense privilege to have shared even a small part of the governance of this organisation, whose whole raison d'etre is to support and look after people, you know, their emotional, psychological and mental health. It's been a truly immense privilege. The whole organisation is filled with the most dedicated, skilled and professional people right across the organisation, and all I can say is it's been a great privilege, and I wish you, every single person associated with Hywel Dda University Health Board, every possible success and blessing in the future. Thank you.
Simon, and I'm sure your words mean a lot to everybody who's listening to them. Thank you so much. I'm going to ask you to come in on the question about the recompense for the money spent at Penally Army Camp. Hugh?
Many thanks, Chair. Yes, there's been a process in place with through Welsh Government and with the Home Office to recompense us for the costs associated with Penally. We started off the process with a number of costs associated with setting up and management costs, as well as the direct clinical costs. I can give you a briefing outside the meeting on the full extent of those, but they have been recompensed through the system. Thank you.
Thank you. Judith?
Yes, thank you. First thing I'd like to do is just, if I could, echo your comments about our 3 independent members who certainly supported me as Vice Chair, but also when I was interim Chair. So thank you for that. My comment actually is about page 5, rebalancing care and support. And just to say that the Regional Partnership Board are also drawing together a response, which will include views from our own officers as well as all of the local authorities. And I would hope that the response will very much tally with the views of the Health Board in response to that white paper. Thank you.
Thank you, Judith. It's really important, and it's wonderful that you're sharing that so we can have that connection. Thank you very much. Owen.
Thank you, Maria. Just to make a comment on the Penally situation, if I may. And I think it's important to recognise the work done by the third sector and the religious and community groups who've been providing practical support and assistance to the residents of unfortunate residents of Penally, and also the role that they and obviously the Health Board have taken in raising the issue through lobbying politicians locally and at a UK level to bring the whole situation to a close, and obviously hope that those asylum seekers are placed in more appropriate accommodation now and continue to get the support and assistance that they need and deserve. And obviously just echo the comments that Simon has made about how much of a privilege it has been to be part of this organisation for a period of time.
Thank you, Owen. I totally echo your sentiments in relation to the third sector and the local community and the faith communities, of every faith who've really gone in and helped to support the men who were placed in Penally. And I'm pleased to say that I'm still in contact with some of the faith communities, and they are continuing to support the men in their new accommodation. And I know our other health boards, such as Swansea and Cardiff, and colleagues who have more experience in this field than we do, have been very supportive as well. So thank you. We also have a question from Delith.
Yeah, Delith said really welcomes the chat health tech service provided. Will this also be available during the school holidays period, or will it be only available during term time? And Rose has answered the question, noting she can provide detail to Delith outside of the meeting, but pleased to note the service has been commissioned for our young people.
That's super, thank you. I'm going to bring in the Chief Executive in relation to Penally Camp.
Thanks, Maria. Well, I just wanted to say and really record on behalf of the board the huge thanks to our teams who have, through what has been a really difficult time for everybody, also including the fact that we're in the middle of a pandemic, have done an amazing job to do their very best by these vulnerable people who were placed in Penally at very short notice. Particularly Rose's leadership and Jill's more latterly, and indeed the primary care team, who I think have just constantly gone above and beyond to keep people safe. In my discussions with the Chief Inspector or the Independent Inspector of Borders and Immigration, he really called out that we had, despite the challenges, had gone above and beyond to make it the very best that we could in a very difficult situation.
Thank you, Stephen. I've had the same feedback from the faith communities about the health input making such a difference to the men at the camp. So a massive thank you. Are there any other questions or comments on my report? Okay, is the board happy to accept the recommendations and ratify the actions undertaken by me on behalf of the board as detailed in Appendix 4? Thank you, Diolch. I'm now going to go to item 2.4, which is maintaining good governance. I think that's Joe.
So thank you, Chair. So this is the update that we've been bringing to the board since the start of the pandemic. I'm not going to go through the paper because members have had a chance to read it, but just to point out, there's one point of accuracy in relation to the QUESAC meetings. The meetings between the chair of the committee and the executive lead have now been stood down as we come out of the second wave. And just to say, we are now looking at what the structure for governance will be in the new financial year.
Thank you. So the board is happy to
approve, because there's a slight change to the command structure, Chair.
Are the board happy to approve that paper, subject to the amendments?
Yes.
Okay, thank you. And thanks again for keeping us safe on this this journey. Next, 2.5 is the report of the Chief Executive, Steve.
Thank you, Chair. I'll be relatively brief because obviously people would have read the paper, but just two things I wanted to pull out in particular. One was just to recognise we have the hosting agreement extension here for the National Imaging Academy in Wales. Just an opportunity to recognise what a huge asset that is to Wales, both in its training capacity in an area where we know we have some real shortages of both medical and therapy input. But also in its opportunities around research and development in AI. It's just a fantastic thing to have in Wales, a real jewel in our crown, I think. And I'm privileged because I'm the imaging lead CEO of Wales, which sounds much grander than it really is. But to keep in touch with the leadership down there about some of the really exciting things they're doing, as well as training the future generation of our radiologists and radiotherapists. The other thing just to mention, we have the triennial review of university health status going on in the background, and the paper sets that out. I know probably other members of the board might want to come in, but I did want to just call out the fantastic and developing work we have going on with our university colleagues. It's of growing importance, and you'll see in the recovery plan, for instance, some of the ambitions we have around research and development and things like workforce planning. Great to see. And I really don't want to steal other people's thunder, but also to recognise that we have growing and really strong relationships also with our colleges. This is a whole education strategy, not just the universities, particularly highlighting Pembrokeshire College, Ceredigion College and College Sugar. I'm sorry if I've stolen anyone's thunder, but I wanted to recognise that actually I think in terms of our links, those developing links for our education providers is going to put us in good stead for the future.
Excellent, thank you. John, would you like to come in?
Yeah, thank you, Chair. Steve, thank you very much for the report. I would like to echo the comments with regards to the support and the collaboration that we get from all our education partners, not only in terms of ensuring that we've got a workforce that's fit for the future, and a skilled workforce to ensure we've got safe and evidence-based care, but also in terms of supporting us around our innovation agenda and our research agenda. And in the last 4 or 5 years, that has made significant difference to the quality of care that we provide our patients and the public. So I would wish to acknowledge the team that have supported this triennial review. It's happening next week. And all the work that our staff are doing in terms of developing this specific aspect of the health board's business. Thank you.
Thank you, John. Phil?
Yes, thank you. Hopefully you can see me or hear me.
We have an echo, Phil. I'm not sure if someone else in your room has a laptop on.
There is
or
no one else in my room.
Okay, if everyone else could go on mute. Including us, perhaps.
So my comment was that you know, this is a really important moment for us. We're really proud of our university's status, and of course, the gathering the evidence is at a time which is quite challenging given COVID, but the team have done quite a remarkable effort in pulling together what we think is quite a wide-ranging amount of activity that backs our university status, but it has been at a quite a tricky time, and just recognise that with the team that you know, we've had to take into account the fact that we wouldn't have perhaps prepared in a different way had it not been for COVID. But we're very much looking forward to the meeting with Welsh Government next week. I think you're now on mute.
Yeah, that's okay. Yeah, sorry, they put me in charge of the keyboard, which is probably unwise. But I think hopefully you can hear us now. Yeah, thanks for that, Phil. And yeah, I would underline both those comments and Professor Gammon's comments. And I think we can approach this process with Welsh Government with real confidence about our ambitions around how we're going to work with all of our education partners, as Professor Gammon has said. And the only other thing I wanted to say, just personally, was just to add my personal thanks to the 3 IMs who are leading us, Simon, Mike and Owen. It's been an absolute pleasure working with you all, more latterly with Mike and Owen, but Simon's been there from my point of view from the beginning. So thank you all for all your support and wise counsel over the years that you've been with us. It's been a real pleasure working with you.
Thanks, Steve. And if I could read out a comment in the chat bar from Paul about our university status and research and collaboration. I concur with Phil and John's comments. Through sitting on the committees, I've seen the enormous amount of work the team have done. So thank you. Is the board happy to endorse the register of ceilings and note the status? Sorry.
So can I just make one comment, Chair, before you approve the register of ceilings? There was an issue raised in the Finance Committee regarding entry number 3 of the Reinvention Cloud Health Centre. So just to confirm to the board that the sale will progress next week. It's just a matter of time until all the governance processes are absolutely fine with the ceiling. It's just to confirm the sale hasn't happened, but it will do next week.
Thanks, Chair. Thank you. Thank you. So the board's happy to, you know, on that basis, endorse the register of ceilings in Appendix A. note the status report for the consultation documents, and approve the NHS National Imaging Academy Wales Hospital hosting agreement. Thank you, Diolch. So the next item on the agenda, thanks Maynard, is the report of the Audit and Risk Assurance Committee. That's over to you, Paul.
Thanks, Chair. As usual, I assume everybody's read the paper. Just a couple of key things to just highlight. First of all, the terms of reference are there for approval. There's no significant changes, or that there's any changes, in fact, to the terms of reference, but they're there for approval. And just to call out a couple of the internal audit reports that we had presented to the committee at the last meeting. The board can take considerable assurance from the work which was done in the quality and safety governance, where there's a reasonable assurance report, which is, I think, testament to the work that's gone on throughout the course of the last year, despite all the challenges that the organisation has faced during that period, and particularly the effectiveness of the IT deployment in relation to COVID-19. The issuing of substantial assurance reports are rare beasts indeed. We had a couple at this last meeting, but this one in particular, I think, just really did highlight the enormous amount of work that the whole team have done, and the way in which they conducted the rollout was regarded as something of an exemplar across Wales. So I think there should be a lot of assurance taken from that, and a thanks specifically to the team involved in that.
Excellent, thank you, Paul. Does anybody like to ask any questions or comments? Well, it's very reassuring and great to see, and you know, the speed in which the IT team enabled us to continue business has been phenomenal. So it was really good to see that report. Okay.
Was it terms of reference, Chair?
Yeah, thank you. So there's also a terms of reference attached to the ARAC report. Is the board happy to approve them? Thank you. If I could just make a point at the beginning, because we've got a number of terms of reference to approve during this board meeting. It's the right time of the year to do so. But now that we have our draft annual report that we are considering with the planning objectives assigned to different committees, we've also had a change of portfolio in the executive directors that we intend at our next board seminar, which will be next month, to look at our governance structure through those lenses. So although we're asked to approve today, it's probable that this will be subject to change next month. Yeah, so thanks everybody. So the next item on the agenda is the Improving Patient Experience Report, and that is Mandy. And I'd just like to say before Mandy speaks, it's wonderful that particularly during the pandemic, particularly that we're all working virtually, and that we don't have a patient at our board meetings, that we hear loud and clear through this report, as we have at each board, the experience of our patients, and I thank you for that. So over to you, Mandy.
Thank you, Chair. That's I think that's really important to highlight the fact that we continue to try to bring the patient and their family into the room whenever we're dealing with anything in terms of our day-to-day business. I don't know about you, but certainly the story that was provided by Jacqueline about her experience of losing her husband during the very difficult circumstances and the restrictions to visiting that we've had was actually a very powerful story. And I think
Mandy, you've frozen. Should we go on mute again?
You'll see. Can you hear me?
I can now, but you did freeze.
Oh,
so we'll try again. I wonder,
okay.
Well, everybody's got their screen off, but you froze. But we will go mute and over to you.
Maybe if you turned your screen off, if that's okay, Mandy.
Shall I turn mine off? That's it. That's fine. Is that better? Can you hear me now? Yep. Yeah, okay, so I'll crack back on anyway. So what you'll see within the report, hopefully, is that although Jacqueline's story was quite a sad and emotional story, we have focused on a significant amount of work around bereavement services across the organisation, and we are continuing to consult on a local and also contribute to the national consultation around bereavement services, with a focus on looking at how we deliver improved standards of bereavement support and care across the organisation. And you'll see there also the story from Tina about the work that the family liaison officers are doing to try and support families at what has been an incredibly difficult time. We have issued revised guidance to all of our clinical areas to try and encourage them to think very much on a person-centred individual basis when making decisions about visiting, because we do acknowledge that this is incredibly life-changing for everybody involved. The only other thing that I really want to highlight is the work that we've been doing, continually trying to capture feedback, and particularly the inclusion on in this report of the voice of children and young people. And although we've only got 13 pieces of feedback from our children and young people, I think each of those comments are really valuable. And I'm glad that and it is, I have to say, it is because we haven't had as many children into our inpatient areas as we would normally have, which is a positive, but in terms of capturing feedback, that leaves us with some challenges. Complaints themes remain the same in terms of appointments, communications and issues related to COVID-19, but I hope that in the next report that I provide around the single point of contact, you'll be able to see some of the work that we're taking forward to hopefully address some, if not all of that. I'm happy to take questions. Shall I try turning my camera back on as well? I feel as I'm talking to myself.
Thanks, Mandy. I'm going to ask Donna to come in.
Yeah, this is just a comment from a CHC perspective. Our chair, Mansell Bennett, is observing the meeting today, but can't come in sort of orally, so just to be aware he's here. But he attended a board meeting last week for CHCs, and the bereavement issue is something that is of concern to a number of CHCs, because over the past year, obviously, people have had to live differently and people have had to die very differently, and we're anticipating that there's likely to be a significant demand. I'm happy to hear that the Health Board is sort of focusing on this and to identify that it is an issue that's common across many areas of Wales from the feedback we've had. Thank you.
Thank you, Donna. I think that's it is really helpful, and because we recognise the longer term impact if we're not managing and supporting families appropriately. And I'll be able to provide an update at some point later on in the year directly to the CHC if that would be helpful.
That would be really appreciated. Thank you very much, Mandy.
Thank you, Mandy. Maynard.
Thank you, Chair. Mandy, I noticed in the report that there were 3 final reports from the Public Services Ombudsman this month, which have been partly upheld. I was just wondering if you could give us a bit more detail about whether there were serious complaints and what actions we are taking to ensure that people don't feel the necessity to go to the Public Ombudsman.
Yes, absolutely. The one case was about scanning in maternity care, and absolutely that is something that we continue to keep a focus of attention on. And actually it didn't have a significant impact in terms of the outcome or the well-being of the child concerned, but nevertheless that particular point has been taken forward. The other is about one of the other cases relates to how we make sure that when assessments are undertaken, we make sure that the outcome of that assessment is shared with the patient and or their family as appropriate. And again, that has been fed back through to the relevant service, but actually it's something that on a wider basis we need to make sure that we do a piece of work on. And then actually making sure that we transfer all necessary information. If a patient has to go to another organisation for care or follow-up care and treatment, that we make sure that we pass on all information to them so that the care and treatment can be appropriate. So those are the 3 very specific elements of the Ombudsman's reports that were upheld. But what I would say is, from my meeting with the Ombudsman's officer only last week, they are content with the direction of travel that we are making, and we are able to provide them with very good evidence of the learning that we're undertaking as a consequence.
Thanks very much, Amanda. It's really assuring.
Thank you. Owen?
Thank you, Maria. A question, Mandy, in relation to the family liaison officers. Obviously very encouraging to see the positive comments relating to their role in the report, and also I get comments locally from about how important that role has been to them when they've had relatives in hospital. I just wonder about the fact that a number of those are fixed term appointments, and there is now a review in hand as to the future, as to whether there's a sort of risk of a gap between those two things, the fixed term appointments ending and the review coming to a conclusion.
So what I can advise is that we have in fact taken on some additional family liaison officers. The contracts of the staff that we have currently are with us until at least the end of June. And one of the pieces of work that we're undertaking is looking at how we wrap the team around the patient. So it's a slightly different model of how we actually ensure that patients receive care throughout their stay in hospital with us. And I'm looking at how we can integrate the role of the family liaison officer within that overall team that we wrap around the patient. It's not going to be straightforward or simple, but it is a piece of work that we're undertaking. And I think that as we see potential changes in relation to the easing of restrictions and potential changes around visiting arrangements, then we will have to adapt and change the way in which we have either family liaison officers or links with families going forward.
Thank you.
Thank you. I'm going to bring Jo in on that particular topic.
Yeah, just to declare an interest, Chair, in that item, just for the minutes. Thank you.
Thank you. Simon.
Yeah, thanks, Chair. Can I compliment Mandy on this excellent report? And I'm particularly pleased to see the compliments section, and especially the informal compliments that normally, as an organisation, we wouldn't have picked up. That degree of informal compliments, over 240 in just a brief period, shows a really important source of narrative, rich source of narrative, which, you know, we can learn from. And for me, seeing those compliments really does demonstrate that the organisational values of the health board are actually, you know, it just shows that they're sort of being practiced, especially the sort of the care, the empathy, and above all the communication. Thank you.
Thank you. Thank you for that acknowledgement.
Thank you. I'm going to bring in Steve.
Yeah, I mean, really just building on that point, I guess as we're about to talk about the annual recovery plan and our strategic objectives, actually this sort of information will form a really key part of board assurance in the future about whether we are making progress against those strategic objectives, 3 of which of course are our organisational values. Just to have in mind, I think that we need to be bringing these reports as a suite of documents regularly to board, so that we can assess, regardless of what we're doing in our planning objectives, whether we're really making the progress to be the sort of organisation that is encapsulated by those values. It's just kind of plant that today because we are actively working on that at the moment.
Yeah, thanks, Steve. And I think, you know, those values and those strategic objectives, and Donna raised the issue about the impact of the bereavement on members of the public. There's been a huge impact of that bereavement on members of staff who have had to step into the shoes of families during the pandemic when people were in hospital. And the other impact for this kind organisation, or a best organisation to work in, has been the family liaison officers, both on patients and families, and again on staff, because it's enabled staff to do what they are best to do, and it's still had the time for the care and the compassion and the kindness for our patients. So as you know, as a board, we really support the family liaison type of work going forward in the future, whatever model that comes out of this. Can I also say, I also love the fact that the patient experience team did a draw for the compliments, and and arrange prizes as well, and that fits into our recognition. And they've done that, you know, by themselves, their own initiative. So it's really, really good. So thank you. John's got a comment that he welcomes the initiatives to communicate with our patients. Understandably, people are anxious at this time, and we need to double our efforts to reassure and support. Any other comments from the board? Okay, I think again it's re-emphasised the importance of this as it falls within our strategic objectives that we've signed up as a board for our care of our patients and our staff. And Mandy, you've agreed to update the CHC later in the year on the bereavement services, so thank you. The board's happy to note the report, and thank you to the team, who I expect are watching as well, because they are very dedicated and take great pride in the work that they do. So thank you.
Thank you. We're certainly very fortunate with the team that we have.
Absolutely. So the next item on the agenda, again, is Mandy, it's yours, the single point of contact.
Thank you, Chair. Yes, the single point of contact is a piece of work which, in fact, Mandy Davis, who's the Assistant Director Quality Improvement, who is leading this piece of work, and I met with Steve earlier this week, because the scale and complexity of the work is quite significant. And I think when any one of us first embarked upon this, it felt as though it was a simple letter that we were constructing and sending out. But actually, what I would like to say, and I would like to thank everybody who has contributed to shaping and influencing the first letter that has gone out to over 6,000 people who have been waiting for 52 weeks or longer, to explain what we're going to do and how we're going to maintain contact with them. We have sent out 300 letters specifically to people in the orthopaedic, first piloting of the work that we're doing around our single point of contact. And already we're beginning to get responses back within the first few days of those letters landing, and that's a really positive position to be in. Initially, it's around validating their experience, but actually from there we're going to go on to being able to signpost and support them to manage their conditions whilst they're put through the appropriate treatment plan and programme. So the detail, we wanted to provide you with almost a step-by-step sense of where we've come from to where we would like to be going in the paper. And I don't particularly want to say anything more, but I'm more than happy to take questions.
Thank you, Mandy. We've got a few people who would like to ask questions, so I'm going to bring in Judith first.
Yeah, thank you. Mandy, when I was rereading this paper, it did occur to me that there are an awful lot of similarities with my experience when I was at WAST in the establishment of the clinical desk, and also prior to that, the actual establishment of NHS Direct Wales. And I just wonder, it wasn't mentioned in the paper, whether there's been any links made with WAST, because they actually run, I know not with so many services, but the whole issue about having a script, communication, people ring with everything that they then need to know where to direct. And yet it wasn't mentioned as an organisation that was being linked with. So it was just a question about whether that had been considered, and perhaps, you know, I would maybe suggest that it would be helpful.
Yeah, thank you for that, Judith. I'm not sure whether they have linked directly with WAST. However, what I do know is that because this work is being taken forward as and is engaged in the Bevan exemplars, a wide range of stakeholders have been brought together to support us. Now, the script development is specific to the services that are being provided or enabled for patients to access. So they're very specific in the first cohort of patients to the hip and knee patients. So it's the level of clinical detail that we need. So the engagement with the clinicians has been critical in this. That said, what we have been doing is looking across the UK, not just in Wales, to see where examples of this type of work has been undertaken before, so that we can pinch with pride those areas, or steal shamelessly those areas that have worked extremely well. But I will go back and make sure that Mandy has brought WAST into the conversations.
Okay, thank you.
Thank you, Paul.
Thanks, Chair. Yes, Mandy, obviously this is a very welcome development. Related obviously in our annual plan that this is something we're going to be developing. There are slight differences between the way in which this SBAR is presented and the way in which it's reported in the annual plan. I take it that it's the annual plan methodology, if you like, follow, and particularly the intention to try and identify alternative care pathways maybe for patients who are contacted through this trial. And then my second follow-up point would be, when do we anticipate being in a position to feedback on the outcome of the trial?
So thank you for that. We are using a consistent methodology underpinned by quality improvement. So this is very much, this first cohort of patients is very much our proof of concept. So what we will be doing is rolling out, learning the lessons. As you quite rightly say, we need to stop, evaluate and learn what is it that we need to do for the next cohort of patients and moving forward. And I have asked Mandy to share with us through the Quality Committee in June an update report on what we've learned so far. So that will be what drives us to actually move from something that is for a relatively small cohort of patients all the way through, because we know that one size won't necessarily fit all. In terms of the rollout across the overall organisation, I'd love to sit here and say we'll have it all done by the end of this coming financial year, but I know that we're not going to be in that position because of the complexity. What I think we will be able to do is in the next 2 years be in a much stronger position than we are now, where we have that raft of information available for patients. A lot of it will be dependent upon the pace at which we can roll out, hopefully no further pandemics or waves come along, because we would have loved to have been a lot further forward now than we are, but unfortunately we've only been able to go at the pace that we've been able to bring services together to get us to where we are today. So certainly by the end of the next financial year, I would hope that we've covered far more services, and then the following year I would hope that we're flying actually, and that we've covered most of the organisation. There will, however, and I must say it, be work that we're going to have to do around the multiple single points of access that we've got across our organisation currently, and that is quite a big piece of work as well.
Thank you, Mandy.
Steve?
Diane, just to say, I think this is a massively transformative piece of work. Those two planning objectives together that Mandy sort of referred to, the bring together all of our various single points of contact, if that's not a contradiction in terms, into one place where we can guarantee good Welsh language adherence, we can guarantee that the patient will be put to the right place, and the clinical involvement that we've seen, I think, will be fantastic for us and take us a long way forward in some of our ambitions. I was just going to mention, in terms of looking forward, the committees will have an opportunity to look at our implementation plans in more detail for all of the planning objectives that are included in the annual plan today. And I will be bringing back an update to every board meeting on progress against all of them at a sort of high level to keep the board apprised, much like I do for COVID now, but we'll do it for the entire plan. So I think going forward, all of these things, hopefully the board will be able to see together in one place. And if we're really clever, I'd like to also link that to our performance report, so that the performance data we look at is in relation to what we're trying to achieve.
Thank you, Steve. I'm going to bring in one comment and one question. Derek has asked, will the service be delivered bilingually, language of choice for our patients?
Yes, and as Steve has just mentioned, we are working on making sure that right from the outset our services are Welsh language compliant, and certainly in the recruitment of our call handlers we will be looking at whether we can ensure that we've got some Welsh language speakers as a first point of contact. Thank you.
And Donna has put a comment about the Community Health Council welcomes the single point of contact work. Communication is a key issue in concerns and in the inquiries that they get from the public. Can I also say I am really delighted that this work is moving forward, and thank you to the whole team. I think I was in the same place, thinking it was a letter and it was simple, not realising the many different ways that the public try to contact us and get various degrees of response. So I think it's excellent, and I'm delighted, and I look forward to the regular updates both here at the board and also with our committees. And it's wonderful that the members come in as well, so we can draw on expertise. And I do believe this will be a game changer for patient experience as we go forward, because it's nothing worse than being at home and not knowing when your operation is going to happen and not being able to get through to speak to anyone. So a massive thank you for this piece of work to you and the team, Mandy. So obviously, I think the board are happy to receive assurance. And the next item on the agenda is the COVID-19 report from Steve.
Yeah, thank you, Chair. I won't go through the report in detail, but I just wanted to recognise, as you mentioned at the beginning of the meeting, Chair, that this week represented a really important milestone in the fight against this pandemic. It's been a year since the first national lockdown. I just want to firstly thank all of our staff and the public who stood in silent remembrance and reflection on Tuesday over what's been an unprecedented year. I know we use that word a lot, but it has been utterly unprecedented. Also, I know the board will want to send its thoughts and sympathies to the families and the loved ones of those who have lost their lives in the last year. We know, just reported from Public Health Wales in our patch, that's 472 people. That will be an underestimate. And our thoughts are with everybody who's been affected, as well, of course, with those people in our communities and indeed in our own staff who are struggling with the direct and indirect consequences of what's happened in the last year. And I'd like to also recognise our own health and care staff, the length and breadth of Hywel Dda, both in our organisation and in our partner organisations, who have risen to this huge challenge, and they've done so with courage, perseverance and kindness. These moments of reflection are important, just to remember how far we've come. Moving on to the paper, I think looking forward, I would hope you would get an overall sense that it does feel that there's growing optimism, that as the days get longer and the daffodils come out, that we are starting to see significant improvement in the position against this pandemic. The paper gives an update on that position, improving overall, and I would hope that that improvement this time is a slow but sustainable return to normalcy. It'll take probably longer than all of us are hoping, but every step we take, I hope, moves us more back towards some form of normality. Our number of infections have dropped and remain low. I checked this morning against the data that's in the paper on page 2 of my report. Our infection rates across Hywel Dda are slightly, pretty much the same actually, where they were on the 7th of March. So today they're 25.3 per 100,000, a little bit of up and down in our individual counties, and our positivity rate 2.7. Those are very low rates given where we were before Christmas, and indeed where we were even at the last board meeting, as you'll see in the table. The numbers in our hospital have fallen extremely fast, probably faster than we would have expected. In places like Withybush, for example, it was only a few weeks ago where we had, I think, 54 to 55 people with COVID in hospital beds in that one hospital, and yesterday we had only one suspected. I think that's a remarkable turnaround and also gives us some hope. And of course, our vaccination programme, which I am hoping is partly behind some of these improvements. In meeting with the team, I meet with the team regularly, and the amount of confidence that they have that we are on track to deliver first dose vaccinations for everybody in the priority groups 1 to 9 by the 18th of April is palpable. And of course, we're also doing all the second dose vaccines that are coming due. The very latest numbers I have is that as of this morning, our system was showing that we've done 205,678 vaccinations across Hywel Dda. Completely, I'm going to use the word again, unprecedented in our delivery. That's 174,065 first doses. That's nearly 45% of our total population have now had a first dose. For the adult population, it's getting close to 55% of our population, and it's getting into the levels shortly, which Ros may want to comment on, where we should start to see population effects from that level. Of course, it takes a few weeks as well to get the effect of it. The paper sets out everything else. I propose if there are any particular updates that IAMS would like in relation to either the operational or tactical issues, then the execs can answer that. And there's a whole set of revised gold command requirements which you will see have gone into our annual plan, so that we're showing for the whole year what we'll be doing both in pandemic terms and in rest of the response.
Thank you, Steve. I'm going to bring in Mike for the first question.
Thank you, Chair. And can I just say before the question on vaccination, I didn't come in earlier, but I just would like to thank you and the rest of the executive for your kind words earlier, and I echo what Simon and Owen said. It's been an absolute privilege to be part of this board, so thank you. Just in terms of the vaccination programme, I also want to pick up, Steve, if I may, on what you just said. You know, the size and the breadth of the vaccination programme is absolutely unprecedented, so I too want to pay tribute to everybody who's been involved in that. Just an absolutely fantastic effort. My question though, Steve, if I may, NHS England are being quoted in the as asking anybody in England in a priority group 1 to 9 to go on to the online system, which again only applies in England, to book their first vaccination before Monday if they haven't already had their first dose. Now, I emphasise English quite a bit there because obviously that system for online booking only applies in England. I just wonder, could we be clear, please, with the public? What is our message if they are in categories 1 to 9 that haven't had their first dose of the vaccination? What would we want them to do, please, and how are we communicating it to anybody who's not actually listening to this broadcast?
Yeah, thank you, Mike, and I will bring Ros in, but just to say, I mean, as you've referenced, the system is different in England, and they're rolling out the vaccination in a different way from us. So we do have to be clear about the Welsh system. We will be, and Ros will be able to confirm this, sending out our letters from Monday for the priority group 9, that's the 50 to 54-year-olds, and indeed starting to invite people in for the week after the deadline, so the week commencing 19th of April, for those in their 40s, and we'll work systematically down through the age groups from that point. So whilst we don't have an online booking system, what we are doing is now booking our clinics beyond priority groups 1 to 9 in the coming week. But Ros, I don't know if you wanted to add anything.
Yeah, thank you, Steve. Thank you, Chair. I haven't got much more to add to that, other than as soon as we've been reaching milestone points. So as we were approaching milestone 1 for groups 1 to 4, we did a very, very robust leave no one behind exercise, where we were calling anybody who'd perhaps changed their minds, hadn't for some reason received an invitation and they were eligible for a first dose of the vaccine, forward through the channel we've got in our command centre, and to get themselves into an appropriate appointment. And we're going to be doing exactly the same in terms of milestone 2, just making sure that we're not leaving anybody behind, and very clear, robust communications, inviting them into clinics before the middle of April.
Thanks, Ros. I think it's, I think we all agree it's been an absolutely phenomenal achievement. Phenomenal. And well done to all, for you and all the teams. Phenomenal. And an awful lot of people have come out of retirement, and I know in regards to well-being, because I've been privileged to visit most of the vaccination centres and some of the GP surgeries, it just gives a lot of people hope when they see people who've been shielding for a year coming out and seeing that there's some light at the end of this tunnel. So well, and words aren't enough. Well done. I'm going to bring Simon in, please.
Thank you, Chair, and I concur with the comments made earlier. The response of the staff and the whole organisation to this unprecedented public health emergency has been nothing short of, well, magnificent. It's absolutely without precedent. I just wanted to ask a question about a process. Last week there was a report published, an inquiry into the impact of COVID-19 outbreak and its management on health and social care in Wales. Report number 3, impact on the social care sector and unpaid carers. And on paragraphs 42, 43 and so forth, it references that some health boards have been sort of asking or requiring care homes to accept people discharged from hospital without a negative test result. So there are circumstances that there have been some unsafe hospital discharges. It doesn't mention which health boards. I suppose I'm just seeking assurance that hopefully that wasn't pertaining to Hywel Dda, and there's also it's contained in the recommendation by the committee, recommendation number 4 on page 19. So I'm just seeking the assurance, Chair, that perhaps that those unsafe discharges weren't sort of applicable to this health board. Thank you.
I'll bring Jill in.
Yes, thank you, Chair, and also thank you for the question, Simon. Sorry, I think we've got a bit of feedback, so hopefully you can hear me, Simon. Yeah, thank you. I think it's fair to say that right at the start of the pandemic, back in April, in March, in fact, there was no guidance on testing, as the board will know, and our desire was to do the most important thing for patients. So a number of discharges did happen very quickly from our hospitals across Wales into care homes at that point in time. And that would have been from March through until April the 22nd, when Welsh Government did issue guidance on a negative test before discharge to a care home. But since that time, as the board will know, we've operated a health and social care tactical process, and we've continued to ensure that any discharges adhere to the Welsh Government guidance that was in place, that has continued to be in place. And it was slightly relaxed actually in December of last year, where there was a recognition that 14 days post positive test, patients are unlikely to be infectious and should still be able to be discharged to a care home, and that was a consequence of the fact that we continued to see some individuals, a small number, who would repeatedly get a positive test. But just to provide the board with some assurance, we went back to do a retrospective review of the patients that were discharged during that first month at the start of the pandemic, and it was a point at which, as you know, we were working with providers around PPE. We were trying to ensure that people were discharged to the safest place possible, and so any discharge was done with that effect. But we've correlated the evidence between the individuals who were discharged at that time and where any outbreaks did occur in care homes, and there was no reconciliation between those numbers, so we were assured from that perspective. But I do want to assure the board that since that point in time, we've reviewed the evidence jointly with our health and social care tactical teams, our microbiology team and our infection control team throughout that process of the last months, but we've continued to adhere to the guidance. And just finally, when I did look at that report, I noted that the inquiry only spoke to ADSS Cymru. They didn't actually come to the NHS for a response in that. And so I would hope that whilst there possibly are some care homes that have experienced pressure in the way that is set out in the report, it's not in Hywel Dda, and I would hope that it would be a minority of places across Wales. Thank you.
Thank you, Jill.
Thank you.
Steve?
There were no other questions. There was just something I wanted to clarify, that's all.
Okay, can I come in on that point as well? And I know, you know, as a chair, listening and watching and being part of the Girl Command, that we stepped into the care home space very, very, very quickly and focused on doing the right thing. And our care home escalation framework was the first in Wales and adopted throughout Wales. And I just want to say thank you, Jill, to you and the team. And it is assuring to hear that you've done the retrospective review and correlated the evidence. Gives us more assurance. Thank you. Steve?
It was slightly understated in the paper, but I just wanted to clarify for the board one other point, which is covered in the recommendations around the chair's action we took in relation to field hospital notification. Just to sort of pull the threads of that together, the revised Gold Command requirement on page 3 of 12 of my report, which sets out the modelling upon which we've made our calculations, which doing the maths on that means we would need to ensure that at a concurrent peak of COVID and non-COVID, we would have to have 945 beds available based on our modelling. In doing that, our need for field hospital beds now stands at about 100. So when you add that 100 to existing beds in our hospitals, to the contribution that we now know that South Thames Hospital in Tregaron can make, and some surge bed availability within Glangwili, those add up to sufficient beds to cover the need. And in making that decision, it became clear that we could then give notice on the Parker Scarlet's Barn, Bluestone plus Krug, and the Aberystwyth Centre. I just wanted to record sort of publicly our thanks to those partners who stepped forward, who allowed us to remove their contents from those buildings so that we could get those field hospitals ready. I am really pleased that, with the exception of Bluestone, we haven't needed to use them during this pandemic. They were always an insurance policy for us, and it was reassuring to know they were there, given what we were seeing, of course, back in March in places like Italy and Spain. But I'm also really delighted now to be handing them back, so they can be used for the purpose for which they were originally set up. So we have written or are about to write to all of them to thank them personally, but I just want to record that for today and say the Chair's action was taken in the context of that gold command instruction.
Thank you, Steve. Are there any questions in relation to the rest of the report or the issues in the field hospitals decommissioned? May I add my massive thanks. It was a real community effort from all our partners to ensure that we were ready should need be, based on what we saw elsewhere and our own modelling. Okay, is the board happy to ratify the decision taken under my action to serve notice to the field hospitals located at Bluestone, Parker Scarlets and Aberystwyth, and ratify the adjustments to the existing Gold Command planning requirements for inclusion in the 21-22 recovery plan?
And just to clarify, Chair, the reason we didn't put Plus Crew on there is because we're simply handing it back. It wasn't contractual serve notice.
Okay, that's wonderful. Thank you. Yeah, thanks Judith and everybody else. So the next item on the agenda is the draft annual recovery plan. I'd like to thank members who have fed back a lot of their views and thoughts and questions in advance on the recovery plan, and also how it has been scrutinised in its iteration. And I'm going to hand over to Steve now.
Yeah, thank you, Chair. And again, I won't go through in detail, and actually we've referenced some of this as we've been through the agenda, but it is firstly to note that this is in draft today for a number of reasons. This has been probably one of the most difficult plans to bring together in terms of the uncertainty that we currently face. And that uncertainty comes from a number of different sources. The unsurprising one being how this pandemic will continue to evolve, the constant worry around new variants, also the impact of the easing of restrictions, and of course the public's willingness to continue to adhere to those restrictions. I would, however, say locally the level of compliance, I think, in our 3 counties has been commendably high, and we are really grateful to our public for continuing to follow those guidelines. But we also need to recognise, following this annual milestone I referred to earlier, that people are tired and are desperate for a return to normality. So that adds some uncertainty to this. On the positive side, of course, we do have the impact of the vaccination programme, and evidence is building both nationally and internationally about what we should expect, not just in hospitalisation and serious illness, where the data as it stands internationally seems to be supporting very much the trial data that supported the initial permission to use these vaccinations, but also that's beyond what we would have expected or hoped for in terms of potential to reduce transmission rates. It's still uncertain scientifically, but it is growing, that evidence that it could have an impact. And of course, alongside that, we are trying to refocus ourselves on that recovery at a time when we have to recognise our staff are only just coming out, our operational staff are only just coming out of dealing with the latest wave, the big wave that we have just been through. There's going to be much more work needed, therefore, on much of this, and we should also recognise that where we are in the political cycle with Senate elections due in May, and understanding the priorities of any new government or whatever that might look like coming forward. Despite that, we have needed to try and set out as clearly as possible what we will be doing in the next year, and what the board will recall back in September, and then with a follow-up paper in November, including some of our cluster plans. that we agreed back then a set of strategic objectives, as I've referred to in earlier parts of the agenda, and a set of planning objectives. And we've tried to use those as the basis for this to set out clearly what it is that this board would like to achieve over the next year, really learning from the clarity that we attained through the command structure and the sense of empowerment that gave to our teams. So the structure of it, you will see, sets out unashamedly and upfront that recovery for our staff is the first thing that we need to attend to. This will all be wrapped around, as I mentioned earlier, a board assurance framework that will enable the board to see whether we are on track with our strategic objectives. And we've set out some ideas around how we might measure those things going forward. And we've got a workshop this afternoon to take that further forward. Alongside section 1, so focusing first on how we thank our staff, give them time for recovery and recuperation, and do the work that Lisa is leading in particular around all of our HR processes. We've then got a section on how we're going to recover our services, because of course we know, as Mandy's referred to in her work around single point of contact, we have many thousands of people waiting for our care, and we need to start stepping those back up. So section 2 really sets out our proposals around that and some recovery. And of course, we are both in discussion with Welsh Government about that, because there will be financial commitments, and it was welcoming to see some announcements around potential money this week from Welsh Government to start so that we can start that work. And we're also in detailed discussions with our partners, particularly in Swansea University Health Board, to ensure that there are regional approaches where those are appropriate for our patients. Section 4 sets out the enablers that will enable us to move forward with all of those planning objectives, and that will form the formal work plan for our strategic enablement, which is led by the Director of Finance, and we'll take forward a number of things, not just in the digital realm, although that will be important. And then section 5 sets out for us the financial and workforce consequences of all of that, and some really detailed work actually has been undertaken by Lisa and the team at Workforce, and we'll be looking to link that into our education providers going forward, so we've got a very clear plan around how we can address some of these longer term planning objectives with the right workforce for the future. I'd probably stop there in terms of the structure of this. As the chair's already mentioned, we did have an opportunity to discuss informally with IAMS earlier this week, and this is an ongoing development. The aim overall, my aim overall, is that we will bring back a finalised version of this in June, with taking into account all the feedback we've had, and hopefully by then with some reduced uncertainties in relation to the things I've talked about. And that will include the development of our board assurance framework, those links to those national work programmes, particularly in the digital field and in the field of Health Education Improvement Wales and their work. Importantly, our route to financial recovery and how that's going to look over the longer term. And I'm asking in the meantime for our committees to start to scrutinise the plans that underpin these, so that by the time we come back in June, there's a real sense that we know what we're doing and we've got a plan underpinning that we can then, as I referred to earlier, just report the progress update to board whenever we meet in public.
Thank you, Steve. I'm going to open it, please, to comments, questions. John?
Yes.
John, would you like to come in and say it?
Thank you, Chair. Just for a board assurance and public assurance, there have been numerous occasions where this annual recovery plan has come to PPAC for consideration. Fully accept as a subcommittee we did that this is an iterative process. I think the committee certainly welcomed the structure and the new approach that has been provided. Much easier to understand the direction of travel that we've got as a health board. So it's just for assurance that we have gone through a measure of scrutiny to date, accepting that it is iterative.
Thank you, John. I've just heard that the members of the public are finding it difficult to hear us, so we'll try and speak a bit louder. Hopefully that's better. And I'm sorry for those in the room if I'm going to speak too loud, excuse me. I'm going to bring in Michael and then Judith.
Thanks, Chair. Just a few comments from me, if I may. First, to commend the team. I think it's a really, really good plan, given just exactly where we've been and where we are at the moment. To be able to produce a plan with such maturity, I think, in connectivity, I think is commendable, and we should note that. I think also because it's sort of recognises it's a plan of two halves. So the first part of the year we'll still be grappling with the pandemic. Second half of the year, hopefully, we'll be starting to think a bit more about business as usual. So I think it's worth just highlighting. I think there are some really important signposts included in the plan that point us into the longer term rather than just constantly thinking about kind of the next month or the next 6 months. So I think from that perspective, I think it's a really good plan. I think I also would highlight the fact that we've been able to align the objectives with the individual subcommittees. I think as a finance committee chair, that certainly will help the finance committee in its job in sort of holding the executive to account and giving assurance around those aspects around the financial elements of the plan. So I think that's really important, I think, going forward. Too often, I think we produce a plan and then forget about it and then just get on with the day job. I think this gives the subcommittees an opportunity to just really just keep coming back to where are we in terms of our overall direction. I think the other point I would make is it's built on some quite sophisticated techniques and models that we've worked on as a board over the last 6 months. We're learning how to use those tools, and there will be moments where it will seem a bit not quite sure I understand how that's working. We should hold true, I think, to stick with what we think are the right tools for managing the board and managing the organisation going forward, particularly around patient reported outcome measures, value, improving together. These are really sophisticated things and exactly where the health board should be. I thought I'd just take a moment as finance committee chair just to mention the money, if that's okay. It is clearly a plan that's built on two halves. We recognise that when the finance committee looked at the financial plan, we recognised the first half of the year will be focused on COVID, and the second half we've got to do a lot of heavy lifting around striking balance to achieve our control total. This year, 16 million in savings. I think what the finance committee will be looking for is, our sixth strategic objective is sustainable use of resources. So we will hope that some of the initiatives that drive out the 16 million savings for 21-22 start to position us in the sustainable route map to financial balance, and some of the really quite challenging decisions that will have to be made over the next 2, 3, 4, 5 years. This is the year really from a finance committee perspective we'll be looking to see that the health board is starting to grapple with some of those really tricky things. So no questions in there, just some reflections, I think. But overall, I think it's a great plan. I know it's iterative. I know it's not quite there yet. It's a really something that the team can be proud of.
Thank you, Michael. And Judith.
Yeah, thank you. Apologies. I'm having to keep messing with the microphone in this room, so I can't always hear what you're saying in the boardroom. Yeah, I just want to echo what Michael said. I think it is a really good plan. I was reflecting again on the section and the services around children. And I think with the theme of connectivity, the section which is under planning objective 5.1, which talks about children and young people services, I think I would sort of ask a question if it could be considered that links to the CAMS in a more overt way, because it talks about school nursing. We've also got the whole schools approach. We've got the Together for Children and Young People. I sort of just was reflecting that maybe the plan would hang better if there was a whole section around all of the services for children and young people, as opposed to maybe having it split, because that's the way we manage it. So I think that would be my sort of comment, having reflected on it a bit more. Thanks.
We'll take that forward.
Thanks, Judith. I'm going to bring Hugh in to respond to Michael's comments. Hugh?
Diolch yn fawr, Cadeirydd. Yes, thanks. My response really is just to pick up one crucial bit of information there in terms of what's happened to our underlying deficit over the last year. Because of the impact of the pandemic and because we weren't able to deliver savings at the anticipated level at the outset of last year, our underlying deficit has gone out by about 32 million. So we're starting off next year with an underlying deficit of 57.4 million. That drives a different set of thinking around how we recover that. No longer can we think about the ways that we were looking at financial recovery over the last few years in terms of turnaround. We now have to think about a series of decision points on our journey to delivering financial sustainability. And the important thing is that I think those decision points do need to meet a financial criteria, they need to meet a quality criteria, and they need to meet a performance criteria, and deliver against all three. That will be a challenge, but my assurance to the board is in looking at a financial recovery plan for the organisation, we will be cognizant of all of those elements in taking decisions and bringing options through to the board.
Thank you, Hugh. I'm going to bring Maynard in.
Thank you, Chair. It's just a very quick comment. As you'd expect, as the IM for ICT, really pleased that right through the plan there's the element of digital touching almost every part of the future. But I think one of the things that I have concern for is the digital have-nots. And I think that's particularly prevalent amongst our elderly population. I've been surprised through personal experience about how many elderly people literally have a mobile phone but no other form of digital for communications. And I think we just need to consider how we communicate to that population and how we support them in the use of any service that becomes primarily digital. Thank you.
Just on, I think it's a really important point made on, I think partly by way of reassurance, but also about thinking about the future. The digital options need to be options. They can't be requirements to get to our services. So we do need to think about those people who won't be able to access in that way. And also, I think there's an opportunity for us through the piece of work we want to do following the elections, which is to talk to our public about how the last year has felt, to get really rich feedback about the necessary shift to digital that we undertook during the pandemic, and really get good feedback. So I think there's a whole spectrum of people, and that will give us more evidence upon which to base the sort of service design issues, because there are some who, as you say, absolutely can't use digital. My dad's got a mobile phone. If you ring it, it's never on, and that's all he's got. But there are some people in those age groups who we shouldn't assume, of course, don't like digital or wouldn't want to use it if they were given a bit of training. So there will be other things that we can also do, as well as those digital natives, the younger generation who've grown up with all of this. So I think we need to ensure that we've got tailored services digitally and physically that can enable everybody to access. Our point needs to be really easy access in the most appropriate way. For your care. Yeah, and can I concur with that? And during the pandemic, it was also raised by the GPs, their concern. I think Sean raised it at one of our workshops, and about having hubs for people to go to where people can physically go to places where they don't have access and there's someone to assist them. So there's a partnership, third sector, local authorities, the community. There's also a good piece of research which will give the evidence base of Connect, of people who use digital and who don't in Wales. So I can share that with the team as well. So thanks for that, Maynard. And there's a lot of agreement in the sidebar for that point. Anna.
Thank you, Chair, and just to echo my colleagues' comments that I think this is a really clear report, a clear format, and a relatively easy read considering the complexity of the topic. But there are 3 specific questions that I'd like to raise, if I can, please. The first is to understand more about what we're doing to ensure that our workforce plans are grounded in the latest scientific research. And that we apply the same standards around our workforce evidence base as we would for any clinical activity that we deliver. And as part of that, thinking about how our workforce plans are sufficiently flexible to the very different needs that our thousands of staff will have experienced, their own unique experiences of moving through this pandemic. So that's the first question. The second question, a change of tack really, to just ask something around to what extent the exec is considering changes necessary in the unscheduled care pathways in order to ensure resilience in the planned care pathways to deal with the backlog that we've got there, given the interaction between those two core parts of our business. And then finally, a question around mental health, and this may be just my interpretation of what's written, or maybe something more substantial. My sense of reading the mental health section is that there seems to be an implication that for specialist mental health services, we won't have too much to worry about in the wake of COVID, and that most of the impact will be felt in tiers 0 and 1. And I think if that is what we're thinking, then we're probably underestimating what may be around the corner. And while I entirely accept the fact that for sort of the bread and butter of specialist services in terms of, say, schizophrenia or bipolar disorder, the pandemic is not making a huge impact in terms of prevalence of those needs, the widespread psychological consequences of the pandemic will sooner or later hit our services. And I think the horizon scanning around that suggests that while there are a range of views on the scale of that, it certainly won't be business as usual for specialist mental health services, and that needs to be really clear in our planning moving forward. Thank you.
Thank you, Anna.
I'll come in and then maybe a couple of the execs might want to come in as well, but thank you, Anna, for those. I'll just deal with them from my point of view, and then I might ask the execs just to respond. So on the workforce one, I think it's a point well made. I'd be interested to get Lisa's view, I think, particularly around how grounded this is in the latest scientific thinking. I mean, I guess it would be fair to say, without prejudging what Lisa's about to say, that there's probably more we need to be doing in that regard, particularly, some of the significant shifts in the type of workforce. Mandy referred to the team around the patient work, which is getting us, I think, to start rethinking what everybody's roles are. And certainly, although it's only a microcosm of what you talked about, seeing the way in which our field hospitals worked, the different ways in which the team's roles interacted, and how positively that was received by our patients does show us we do need to shake some of these things up a bit, but Lisa might come in on that. On the unscheduled care pathways, I think Andrew might want to come in on that. We do have a challenge with the needing to ensure that we get good access for our population in a very rural community, so and in a moment of crisis. But certainly I think that the thinking around Prince Philip is for additional planned care, not to change the unscheduled care pathway, and that will be the same probably across the patch, but Andrew might be able to give a bit of a bit more meat on the bones of that. So I don't think we're, from my point of view, looking at significant shifts in unscheduled care in the short term. Of course, the new hospital build will be our most significant move and enable us to bring things together. But to go back to what Hugh said around opportunities, we do need to look at all of that, particularly the staffing that we have for those areas and our resilience. If we, as expected, will need to maintain red and green pathways, essentially that means we've had to double our front doors across the health board. And then on mental health, I mean, I think there is certainly more to do on this. There's a lot of emerging evidence coming through from Public Health Wales about what the likely impacts are going to be in the short, the medium and the long term. I think this plan suffers a bit from that still being developed, that thinking still coming through, given that we're probably only at the beginning of that. I would say, I mean, I think there will, just from my sort of layperson's point of view in this area, you're right, there must be a consequence for our specialist services from what we'll see as an increase. However, our model, you know, that model that we based on one of the best places in the world, Trieste, around the benefits of prevention and very early intervention, really reducing your need for specialist care. I would hope that puts us in a relatively strong position to ensure that we have less of that impact in our specialist services than perhaps areas that are not focused in that way. And of course, one of the huge benefits one of the benefits we've seen from this pandemic, one of the positives, has been the significant shift towards that community model, that walk-in model of health and care support in each of our counties, which the Transforming Mental Health plan expected to take us a couple of years to get to. So I think there's definitely some things to work through there, but we are starting, I think, from a different base, given that we had that Transforming Mental Health strategy being implemented. But I wonder whether Lisa might want to come in on workforce and Andrew either on the unscheduled care thing or the mental health thing.
Lisa.
Thank you. As usual, Anna, a very deep question for me to think about. We have expanded our workforce planning team, and part of the role of that new team now is looking for evidence-based practice around new roles and different ways of working. And they work very closely with all of our health professionals across the organisation in terms of the information and evidence that they have about different roles. It is something, as Steve has mentioned, that we do need to look at more, and I would like a conversation with you after today as well around your thoughts on that. In terms of flexibility for the future, it is absolutely at the core of what we need to think about. So part of the development plan is around what are the core competencies we need that we can then use for multi-professionals, and how we create the more generic worker so that we can be agile in our approach, and particularly in this year with the unknown certainty around what will happen with COVID, it is absolutely essential that we have a workforce that is agile enough so that we can deploy them in the areas that we need to. So work in progress, it is on our agenda. We are starting that work, but would like another conversation. Thank you.
Lisa, I'm going to bring in Andrew.
Thank you, Chair. As always, Anna, questions that challenge me on a board morning. I think Steve probably, actually, in thinking about what Steve said in terms of both topics, he's probably at one level covered a lot of what I might have said. I think what I'd want to ask, what I want to add is, and just to give some assurance, I think that the unscheduled care question is an interesting one and a good one, because I think one of the things we've seen very quickly after the second wave through March is a very rapid return to our non-COVID levels of emergency demand in terms of admissions. We've not necessarily seen attendances increase to the level they were pre-COVID, but we're certainly seeing a higher proportion of admissions from what is coming through. And anecdotally at the moment through March, the message I'm getting from the frontline teams and the services is there's more acuity and more complexity in what's coming through. So what we're just trying to understand at the moment is whether that's a short-term blip in response to the impact of the lockdown that we've had, and perhaps some of the anxiety the public have had around accessing services whilst incidence of COVID was high, and some of the messaging around wanting to stay away from hospital for safety reasons, despite our best efforts on that front comms-wise. But we'll keep a close eye on that, and I haven't got at the moment any information that starts to articulate what the themes within that might be as well, to know whether it's specific conditions that are causing us that challenge. But that's something the teams are working on, because it's, as I said, it's a live issue through March. So that's something that's a challenge, and that's why. But I think our overarching plan for unscheduled care, and the fact that we're so clearly focused on how we develop the urgent primary care model, how we develop same-day emergency care, is all focused on how do we reduce attendances and how do we keep people out of hospital, how do we best use telehealth alongside those actions to help advance that even further. And that's all important, because one of the challenges we've had on the specific point of the planned care, unscheduled care dynamic and the COVID impact on that we've seen, is that when we've done the initial analysis at the moment of the scale of capacity we would need to either accommodate all of our planned care on a single site, or all of our or co-locate some of our and reverse co-locate some of our unscheduled care in a reciprocal way. We don't necessarily have sites as things stand that would be able to cope with that level of activity, either in the planned care sense or in the unscheduled care sense. So we still need to be very focused on some of that and all of that improvement work, really, to help us within our current configuration. But if we wanted to look at how we could potentially be how we could potentially accelerate some of the thoughts that were coming through our clinical strategy that we signed off a couple of years ago, we're going to have to focus on those to make some of that work in an interim period. So it's work that we've looked at and work that we'll continue to come back to and review. And at the moment, some of the options that we're considering around trying to increase some of the footprint through the use of demountable facilities potentially on sites would help generate a bit more of that physical separation and protect our pathways been able to through the pandemic so far. I think that with what Steve has said probably covers unscheduled care. In terms of mental health, I think again I think we are in a space at the moment whereby there's still work being undertaken at a national level, as Steve's articulated from Public Health Wales, understanding what some of that impact is going to be. I know there is a fear when I talk to the service and the clinical leaders in the service that there is a risk with this that we create a mental health crisis if we don't respond in the right way. And I think one of their fears is with the limited expertise we've got at the specialist end of the mental health workforce and the difficulty that there is recruiting to those posts and the fact that everybody would be looking at that we really do have to focus on how can we stop the escalation of illness in that way. So that's why there's such a heavy focus on at the moment anyway, on the tier 0 and tier 1 aspect of the plan, because that's areas we know that we could probably do more in to have an impact. That's not to say we're sat there thinking there's not going to be any flow through, because with anything there's always be patients and individuals that will escalate through the pathway. But I think it's around a recognition at a national level as well, not just locally, that that's a gap in the service at the moment that really needs to be addressed. And then as the work emerges on what else we might see, we'll obviously have to look at how we respond to that. And when we talk around the performance, we may get back onto this topic a little bit as well. But I think it's worth noting that we are seeing, to emphasise your point, we are seeing an increase in referrals into some of our specialists at the moment, and there've been quite significant increases, and there's an acuity and a comorbidity around those and complexity that we've not had before necessarily from a mental health perspective. So there is already some signs that that's coming through, and it's about how do we work to mitigate that and address that when it presents itself at that more specialist end.
Thanks, Andrew. Chair, can I very briefly make a comment on that last point around mental health? I mean, I think I recognise the the debate that you're reflecting there, Andrew, in terms of mental health. It's a very hot topic in the mental health world, and there are differences of view, which is why I referred to that sort of range. We don't know actually yet, and I think there's a lot going on that horizon, so there's a lot that we can keep in touch with in terms of of different expert views around that. But two, I think for us, it feels to me it's too early to close the door on the possibility that specialist services will see some impact, and that because specialist services across all of our specialties run right at the edge of their capacity already, the headroom for responding to even a small fluctuation in demand probably isn't there, and that will only be exacerbated if there's failure demand coming up into the specialist system because that tier 0, tier 1 support is not there. So I think I know we don't want to unravel it any further here, but I think it is an area where we need to keep an open mind as to possibilities rather than to already determine that it's not an issue.
And I think just to say, I don't think that we'll review the wording of the plan, because I don't think it's our intention in the plan to give that impression. I think it's just about trying to emphasise where a lot of the focus is, where we know we've got a big gap as well, and we just need to make sure we balance that out as you've described there. So I will pick that up in terms of how the next iteration of the plan looks.
Thank you. And if I could also add to the question about the relationship between unscheduled care and planned care, it does also bring into account the delayed transfers of care, because it's the whole system, isn't it, out into the community before and after our acute hospitals, which all interrelate and all impact. Owen has put a comment in the side which everybody agrees with. It's important to recognise the disproportionate negative impact COVID will have on some sectors of the community through increased unemployment, reduced incomes, housing problems, fuel, food poverty, and this will have consequences for physical and mental health and well-being. And we live in a predominantly rural area which is heavily reliant on the hospitality industry, which has taken a huge hit. Those messages are coming down from the government as well, very loudly. And I know we're doing work that we've got under that big word, the foundational economy, because we are an organisation in other ways besides providing healthcare. That's exactly, Hugh says, we have a duty to respond with some of our work on the foundational economy too. We can provide employment, we can provide some of the anchor things within our communities with our partners to help alleviate that, as well as our health work. And I know that's work that's happening, and Hugh, I think it'd be, we would decide where that is going to be showcased within our committee structure so that everybody is aware of that. So thank you, everybody. Are there any? Hugh, do you want to come in now?
Many thanks. Yeah, and happy just to add, there is a significant amount of work that we've started to undertake on foundational economy and on social value that we're generating as a health board as well. It's probably worthy of a seminar with colleagues at some point in the future when we've been able to pull this together into a coherent strategy and we've got something to share back for discussion.
Chair, and I would just add to that the work that Lisa's and Mandy have been doing around employing people, the family liaison officers that Mandy referred to. I think a lot of those are from the hospitality industry locally, which of course has been hit really hard.
Yeah.
And the work that Lisa's leading on our apprenticeship scheme. Yeah. I mean, it was important before the pandemic to get our local kids, local people more generally into good employment with good prospects, good pensions.
Absolutely.
It's even more important now, and I think the response has been enormous, even though it's all had to be done virtually this time.
Absolutely, and I think that's an absolute credit that we are doing both those things. And a lot of the young people ran towards the organisation for work during the pandemic and are still with us. And personally, I know of a number of people who've applied for our apprenticeship academies in the last weeks. I'm delighted that the letters have gone out yesterday for the assessment days, and it fits in with the flexibility, agility of the workforce and the team around the patient. It is superb and fits in with our socio-economic duties. And Lisa said we've had hundreds of applicants, amazing. And I'm hoping, I'm really proud of that scheme, really proud. I think we're the only one in Wales that's doing it, and listening to the apprentices that we have already in our organisation, the difference it's made to them, their families and their lives is fantastic.
They've had a year.
They've had a year, and they've been so flexible. They're everywhere. They're in the testing centres, the vaccination centres, the wards. Absolutely wonderful.
Absolutely.
Okay, so if I could just briefly summarise, a massive thank you to the team. The consensus of opinion is that this is a draft plan and an iteration, but it's disciplined, it's clear, it's logical, there's connectivity. We're using the measurements that are important, such as PROMs and improving together and value-based healthcare, and we are considering the sustainable route map for financial break-even. Personally, I think it's a phenomenal achievement. I've used that word twice. It's a word I don't usually use, but during a pandemic, and I said to Steve yesterday, it's like the fog is clearing before the boat with this discipline of how we're going to go forward based on the learning of the last year. So thank you, everybody, and thank you for all of your input. I'm going to give us a 10-minute break.
Can we just
Sorry, I'm running ahead with myself. Thank goodness for the board secretary. Can we approve the recommendations? Yeah. Diolch, thank you. And on that basis, 10-minute break, 11:20, we'll come back and we'll carry on with the agenda. Thank you. Should we go on mute? Welcome back, everybody. Croeso. We're going straight to the agenda. It's item 3.5 and it's the performance report. I'm going to hand over to Hugh.
Cadeirydd, diolch, thank you. Just wanted to just mention a few brief comments to the board before I open it up for questions. The first one is that the board will note on the SBAR in particular that this is a new way of reporting, which we're trying out in the SBAR for the report, which does highlight in particular the challenges we're facing now through the use of SPC charts. It's a new way of working, and clearly that's going to take some getting used to in terms of the language we use and the approach we use. In fact, I think Michael summed it up a little bit earlier on when he said that there are going to be some challenges for us to understand how things are pulling together, but we'll go with it. And if there are any challenges that members have in understanding this, I'm more than happy to have conversations with members offline, and we will be supporting this with a briefing pack over the next month or so as well to help explain where we are. What it does highlight though are the key issues that we're facing now with ongoing challenges in unscheduled care, which are outlined on the third page of the SBAR. Clearly the increase in waits in planned care, but it does also recognise the improvements we've got in therapies. But in terms of hitting our target in therapies, it does show that we need to still think of a system improvement that we need to put in to drive that improvement further and drive further change. Just a couple of other areas that I wanted to pick up was the impact that the pandemic has had on cancer and on stroke performance, which I've outlined in the report, and of course the discussion we've had in numerous meetings now on the continued decline in their performance in neurodevelopment and psychological therapies. With that, Chair, I'm happy to open up for questions and get into further detail that way.
Many thanks. I'll bring Alison in first to respond regarding therapies.
Yeah, thanks, Chair. It's just really to add that this last year has certainly been atypical because of COVID. But Hugh is right. Historically, we have seen this repeating pattern where we've seen waits starting to grow from April onwards, and then we've had temporary funding to resolve that mid-year with a plan to get that back on track by March, and then we see that bounce back up. I'd just like to remind the board that going back further than the data that you've got in this report, the numbers waiting were far higher. But I do think we've got an opportunity now, because we've been forced into very quickly putting in virtual assessments and virtual appointments. We've got a real opportunity here to not go back to the old way of working. So whilst we've reintroduced face-to-face contacts where they're needed, the plan going forward will be that we'll use a mixture of real face-to-face appointments and still benefit from the virtual appointment system. So I think going forward we do have this opportunity to see a very different way of working. I don't think we'll see a replication of the old sort of rising and then falling. So I just really to give some assurance around that.
Thanks, Alison. It's good to hear that the lessons have been learned and will be taken forward. I'm going to bring Judith in.
Yes, thank you. I guess it's a general question, but I can focus it around the neurodevelopmental psychological services, which, as colleagues know, I've raised on a number of occasions over concerns around the waiting times. And I guess the question really is, well, what next? Because the benefit, I suppose, of having this sort of information is it does highlight, and there's a number of areas where it says without system change, then we're not going to improve. So I suppose I'm asking, so what are the plans? I'm not expecting it to be laid out now, but I just wonder how this is going to be taken forward in the areas where, as with these examples, it does say that we'll never achieve the target unless we change the system.
Chair, just on the generality, and then Andrew, I can see you're on the screen to come in perhaps on the specific. This is a new way of reporting for us, and as I say, we're in that kind of interim stage now of moving into that new direction, but the bulk of the performance report is still on the old way of reporting. I think, you know, this comes back to the basic principle here that we'll be using data for improvement, not for judgment, and I think that it's incumbent on us therefore to report quite differently to the board based on the improvements that we think are needed to recover what are likely to be shown as being issues where a system change is required. So I think that we will have to respond to that new way of reporting, and will keep us very focused on our improvement approach. And that's in essence what the SPC charts are trying to do. But I think what we'll find in the new way of reporting is probably fewer words, much more focused and much more targeted at improvement. In terms of the specific, Andrew.
All right. I think I'm on mute, sorry.
We can hear you.
Good. I was having an issue there. It was clicking on and off. Yeah, so on the specific, I think, this is a really difficult area, Judith, as I know you appreciate, and you rightly raise it on a regular basis and scrutinise it, because it's, even pre-COVID, it was an area where we were struggling service-wise, and I think at the moment there is a sense within the team that the situation is, they feel like they're taking steps and making progress in improving capacity, and that coming up with ideas to try and mitigate some of the challenge we've been seeing. But there are a number of factors at the moment that continue to compound that any progress being seen. So if I just take a couple of seconds just to give you some sense of what has been happening, what some of the challenges are, just so the board have a feel for what we're doing. Certainly in terms of the challenges, I sort of alluded to it in an answer earlier on, but we've seen effectively a 30% increase per month in the number of referrals to these services over the last few months. So that's in keeping pace with what's coming through. There's been a significant change. So it's 96 referrals we receive on average a month now. It was around 70 previously. So it's quite a big jump in demand that we've seen. We know that we've got a limited workforce with the right skills and experience to undertake ASD assessments and diagnosis. We know that there's the challenge of the successful approach to treatment and intervention is face-to-face, and that's been increasingly difficult within the COVID context in terms of available estate accommodation, and in some cases patients' willingness to want to come to face-to-face appointments with everything that's been happening. The impact of COVID-19 on other services provided by local authority and education has made it difficult as well to undertake some of those assessments, because assessments for a number of these cases need to be undertaken in the home and in education settings. So while they've not been there, it's been difficult to fully do those in the way that the service would want to undertake them, because as we said, the online version of that doesn't necessarily work as well in this particular service. They have looked at a number of options to increase capacity. So they've looked at weekend clinics to increase the number of assessments. They've looked at how we could use agency staff to help provide additional capacity, and in particular to offer increased face-to-face assessment capacity. And we've looked at waiting list initiatives to increase the capacity. There's a number of schemes that are happening. So there's pilots with the Pembrokeshire Education Service to enable early diagnosis for standard referrals. There's another pilot been set up to look specifically at the under 5 age group in order to try and help speed up the diagnostic process for that particular age group, which would have a really positive impact. If it's successful, will have a really positive impact on the overall size of the waiting list. And we're looking as well at whether there's any way we could look to outsource some of this activity to try and increase capacity. So I want the board to know that the team are doing everything they can and are constantly looking and reviewing options to try and provide the capacity needed to address the original, the pre-existing and historic problem we've had in this service, but also to try and keep up with some of the changes we've seen in demand in the last few months in particular.
Andrew, and I know John is going to come in, but I think it may be a good idea because this service is, as you said, Judith raises it on many occasions, and it hasn't, despite an awful lot going on, we're not seeing the improvement that we would expect. And I wondered if we could have the roadmap to recovery and the scrutiny of this in more detail at the performance committee. And perhaps the team themselves could present that roadmap to recovery and take detailed questions from the committee.
I'd be happy with that.
Okay, and as Judith said, she knows the team's working very hard, and it comes not to criticise but to understand what more is needed to support the team, and perhaps having that airspace within a committee may assist. And Paul says, in addition, can we look at a service beyond diagnosis? Absolutely. John, I'm going to bring you in.
Thank you, Chair. And I think on that very point around a roadmap for recovery plan, that is the discussion that I had following the last PPAC with Keith Jones this week, because we've requested as a committee a paper to look at that very issue. So thank you for highlighting that, Chair. I think it's important that we as a board recognise the challenge. This isn't going to be something that we can fix within the next few months. This is going to be a challenge for some time, as it will be for all health boards. But certainly as far as PPAC is concerned, and I'm sure as the board is concerned, we need to see what plans have been put in place to address some form of recovery. There are people waiting for our services, and obviously that's impacting on their health and their well-being, and some assurance as to how we are going to approach that. And as I said to Keith this week, we accept as a committee that there are a number of parameters that can influence that, and they are changing. But we still need to have some sort of understanding of what the road and the signposting as to recovery would look like. The other point I would raise, Chair, is that in terms of the performance report, PPAC welcomes the new approach that we're taking to try and understand the data. It enables our interpretation to be a lot slicker and more meaningful, and also it enables us to recognise where we have to change the way in which we do things, as opposed to continually questioning around we need to see improvement, and acknowledging the difference in the way in which we therefore ask our questions as IMs. So just to assure the board that there are meetings that are taking place outside of subcommittees on this very issue, and I have to say I was assured by Andrew's team via Keith this week with regards to what is being considered. Thank you.
Thank you, John, that's really helpful. I'm going to open to any more comments, questions. Hugh, do you want to come in? You're on
Thanks,
mute.
Jane. Thanks, Jane. No, I've got nothing else to add. Thanks.
Okay, thank you. And Andrew saying thank you, John. Okay, I know from the meeting that I held with the IMs on Tuesday, and similarly the seminar where we saw the first presentation of this form of reporting, that we all welcome this new approach. And as Steve says, this new approach, rather than having pages and pages and pages and pages and pages of information, really exposes where we need to change and we need to improve, and there's nowhere to hide. And I think it helps us all as an organisation, helps both the operational side where we focus and the board side where we focus on receiving assurance. So if I could ask that, obviously the road to recovery conversations are happening outside, that John is leading. The neurodevelopment, if that could be scrutinised in a deep dive within the Planning and Performance Assurance Committee, please. And can we come back with the information and the assurance of what we're going to do in relation to the things that need the whole system change?
Yes, of course. Yeah, I'm happy with that, Chair. And also just to reiterate something earlier, when the plans go to committees in relation to the recovery plan for all of our waiting times, which are inherent in section 3,
yeah,
we'll be able to scrutinise the improvement trajectories that we're expecting against things like the plan to care recovery. Indeed, this area. It's really good to see this discussion today. I think as Anna's put there, it's the right conversation.
Yeah.
What I think one of the things we need to guard against, both in our reporting, but also in our response, is that we focus on a few things and getting a few things really narrowed down. So I want to create a very clear link between the performance report and what we've just agreed to do in our annual plan, so that the board can see that we're making progress in the areas we said we were going to make progress in. That necessarily means we may not be making progress in those other areas that are not yet covered, but we've got to do things in order and by priority. So I'm really pleased that we're having this sort of conversation. It's no place to hide, not in a threatening sense, but in a sense that actually we can be really clear about where we are, understanding our problems and what we're going to try and do about it. And I think that's good both for IM assurance, but also more generally for our public assurance.
Yeah, totally agree. Otherwise, you know, we have tended to go into my sort of detail in tiny parts of the system rather than the whole system and our performance and that change and improvement. So I really thank you. It's a maturity, it's a conversation that needs to happen, and it ties in, as you say, Steve, with our draft annual plan and the way that our committees are going to work going forward. So many thanks. I'm going to, so the board, happy to accept the recommendation, and we will take the work forward. I'm now going to go on to the corporate risk register, which is Steve.
Yeah, I didn't know anything specific to say. The board secretary needs to pick anything up.
Yeah, thank you, Chair. So just to add really that there are 22 risks currently on the corporate risk register. They have all been through their relevant committees of the board, and in addition they are reviewed on a monthly basis by the executives at a joint executive risk team meeting. There probably is one, I don't know whether you want to pick it up here, Chair, or through the Chair of Quality and Safety report. We do need to flag to the board risk 684 because it was raised at the Quality and Safety Committee, concerned that the risk has increased in score and the mitigation is holding it there, but there are concerns around patient safety. So I know the Chair of PSEF will raise that in her report. But I just needed to call that out as you're looking at the corporate risk register in its whole. And if there's any questions on individual risks, that we can, individual exec directors can pick those up, Chair.
Thank you, Joe. Anna, would you like to come in and we could pick it up here?
Yes, thank you, Chair. Thanks, Joe, for that. It is really just to reiterate the point that Joe's made, that from the Cusick report, while there is nothing to add, there is that risk to escalate around radiology equipment replacement. And when we looked at this in our last Cusick discussion, we didn't really get a good enough sense of how we were able to push forward with a response from Welsh Government around the funding requirement, and as a result we're kind of stuck, and inevitably over time the risks to service delivery and patient care will be increasingly impacted. So it was an escalation here to inform the board that we can't take the degree of assurance that we would want to around that risk being progressed and reduced.
Andrew, would you like to come in on that particular risk, please?
Yeah, no, I thought it would just be helpful to update the board on some positive news we've had in the last few weeks from Welsh Government in terms of our two highest priority areas for replacement, which was a CT scanner in Glangwili and an MRI scanner in Withybush. We've had confirmation that they'll be supported through the capital programme nationally for next year. So in terms of the two highest priority areas we wanted to address as part of that risk, we have had some positive news, which we're obviously very grateful for. So it was just to update on that, really.
I need to review the risk in that light, then we'll work with Andrew's team.
Thanks, Andrew. Joe's just saying that in the light of that news, then the risk will be reviewed in our risk register. That's great news. Fantastic. Thank you. So everyone happy to accept the recommendation of the Corporate Risk Register? And we'll now go on to the report of the People Planning and Performance Assurance Committee. John.
Thank you, Chair. So the agenda contains 2 reports, one for an extraordinary meeting with regards to our vaccination programme delivery plan, and I've got nothing to add to that report, but happy to take questions. And the second, which was the PPAC committee held on the 25th of February, nothing to note other than 2 areas of concern. One we've addressed, which is the issue of patient waiting times, and I would wish to acknowledge now the work that the operational teams are undertaking in order to try and address this and to apply principles of transformation in how we deal with this going forward. So I think we've covered that one. The other one that I would wish to note to the board is in relation to concerns that the committee expressed around progress with some of our capital projects, particularly the Women and Child Health Phase 2, as a consequence of the discussion there and in terms of the timescales, deteriorating timescales and position and therefore risks. We've asked for a more detailed paper at the next PPAC committee. Happy to take questions, Chair.
John, any questions? Okay, well, thank you. We look forward to the feedback in relation to the delays in the capital projects that you've specified within your report. And thank you for that, Dion.
Thank you, Chair.
The next item on the agenda is the report of quality, safety and experience. Are there any other issues, Anna, besides the one we've just discussed? Oh, excuse me, the board's happy to agree the terms of reference of the committee.
Yes, my apologies, Chair.
No, I'm sorry. And obviously that's subject to, as I said at the beginning, with our review that we will all do together next month. So, Diolch. Okay, Quasia.
Thank you, Chair. And well, with that great news that Andrew was able to give, I can de-escalate that element of the report. We do have terms of reference to approve, please, and I would just like to take the opportunity to highlight to the board the excellent audit feedback we've had from Bwrdd and their participation in the National Hip Fracture audit work. There was actually a fantastic audit report across the board, which is particularly pleasing considering the last 12 months, but a particular shout out for Bwrdd and their contribution to that. Thank you.
Anna, and absolutely agree, and they're delighted there, and it's wonderful. You know, it's not just in Wales, it's in the whole of the UK.
Yes.
They're the outcomes of patients, so it's excellent. I'm going to bring Ros in. I think, did you want to come in on the vaccination programme, Ros?
Yes, and just to pick up on John's point, and also the risk around the delivery of the COVID vaccination programme. Just one point I just want to provide the board some assurance on, and this was regards to the administration of second doses. The data that's been provided in the board papers was from a couple of weeks ago. And 2 weeks is a really long time in the life of the vaccination programme in terms of its pace and scale. So I just want to describe some of the progress we've made around not just first doses but second doses, and also to explain why there appears to be a difference between the level and numbers of second doses between certain cohorts of the programme, because there's a real difference between the rollout of the second doses between vaccines. There's a difference between the Pfizer and the Oxford AstraZeneca, not in terms of the guidance. Both vaccines, the interval can go up to 12 weeks,
But what's emerging very, very clearly is the effectiveness of the Oxford-AstraZeneca vaccine is increased the longer the interval between the first and second doses. So where we've been administering second doses for the groups that had their first dose of Pfizer vaccine, and that is clearly being shown in the second dose figures that are being presented, we are holding off with regards to providing second doses of those that were given Oxford-AstraZeneca as their first dose. And so that's our over 80-year-olds, our 70 to 74-year-olds, and the extremely clinically vulnerable cohorts, and those older residents within care homes, all fantastically delivered by our primary care colleagues. But we are waiting until week 11 to be able to call and have those clinics with regards to second doses of the Oxford-AstraZeneca. I just want to provide assurance to the board that we're doing the right thing, and just presenting the statistics in the way that they are can sometimes hide some really important context. Thank you.
Many thanks, Ros. That's really reassuring. Judith, do you want to come in on Quasiac, or are you waiting for quality health and safety?
No, I'm waiting for health and safety.
Okay, thank you. So the board's happy to approve the terms of reference of Quasiac. Thank you. Judith, Health and Safety Assurance Committee, thanks.
Yeah, thank you. Just to draw attention to the report, and also we'll be seeking ratification of the terms of reference. I would, however, just like to take the opportunity to say that the committee has been really pleased and assured to see the progress in relation to all of the enforcement notices that we had in place, and really pay tribute to Mandy's leadership of this, and also the team under Tim Harrison and the way they've really addressed this, so that we are in a much better position. I can give the board that assurance in respect of our health and safety.
Thanks, Judith. It's really great to hear that, because, you know, and thank you for taking over the chair of this committee, because we were very concerned. That's why we created this as a subcommittee, and it's great to hear that Tim and Mandy have taken the way forward so well. So thank you. I'm now going to go on to Finance Committee. And the terms of reference. Is everybody happy to approve them? Thank you. I think we should just do it en masse, you know. I'm going to the report of the Finance Committee. Michael.
Thank you, Chair. Two finance reports in the papers, those covering our meetings in January and February, where we discussed the financial position at month 9 and month 10. In addition, we also met earlier this week to discuss the financial position at period 11, which Hugh will cover on the agenda next. Nothing in particular from the reports to highlight that's not already been covered in different board agenda items. Just need to ask the board to ratify our terms of reference.
Thank you, Michael. The board's happy to ratify the terms of reference. Thank you. And now I'm going over to Hugh for the finance report, month 11.
Diolch, Cadeirydd, thank you. Just in terms of a brief outline of where we are at this stage, we're still on plan to deliver the deficit of 25 million, which is in line with our original plan that we set at the start of the year, notwithstanding all the changes that we've seen throughout the year. One of the challenges that we've got, which has been addressed with funding during this year, has been our delivery of savings, or our non-delivery of savings through the year. So our plan required us to deliver £34.2 million worth of savings for the year. We've only actually delivered 1.3 million of savings on a recurrent basis, hence the issue when I alluded to in our plan earlier. Now, the impact of that this year has been mitigated by non-recurrent funding that's come through from Welsh Government, but there's a degree of uncertainty on the ability to maintain that into a recurrent funding stream, which is a concern for us in the plan. As we go into month 12, my concerns at the moment are that we require assurances over the delivery plans on ICF and cluster plans just to make sure that we can be assured they will deliver in the final month and there are no surprises for us coming through. And the last element then of significant variability or concern at this stage is the annual leave accrual. You will see in the report a significant increase in our spend on pay in month 12, and that's because we're recognising for the first time, actually, because generally we require people to take annual leave in the year in which we're working, but for the first time we are recognising that in the balance sheet going into the next year, and the value of that is at the moment we're estimating that somewhere between 12 and 15 million. So it's a significant value and some significant variation potentially within that. We're working through that at the moment. I guess the point I'd like to highlight is while there's some financial uncertainty with that and we're working through that, it demonstrates the sheer hard work, the determination of our staff who've not been able to take their annual leave throughout the year. Now, that will be an issue that we need to address next year to make sure that staff have the appropriate space and opportunity to recover and rest and recuperate. But it does, it's the financial indication of the sheer hard work that's been undertaken this year. With that, Chair, I'm happily open to questions.
Thank you, Hugh. I'm going to bring Michael in to comment.
Thank you, Chair. Just to support Hugh's comments, I think really about the financial challenge going forward. I know this particular item is about the current financial year, but the Finance Committee will be wanting to scrutinise over the coming months just what the Health Board's plans are, not just to deliver the financial position in 21-22, but to start to work into the underlying deficit that the Health Board's got, which unfortunately hasn't gone away. It's just different. It's a similar figure, but just differently articulated now. We know the answer lies in our transformation programme, but I think from a Finance Committee's perspective, we see 21-22 as being a really critical year in being able to see that the actions of the Health Board are starting to turn genuinely towards a sustainable transformation programme.
Thanks, Michael. This is a real opportunity, isn't it? It's almost, you know, a mark in the sand after this last year, both in terms of governance, finance, performance, quality. So thank you.
Yeah, so apologies, Chair, just to come back on the back of that. I fully support that, but I also, we need to recognise some really hard decisions to be made in there. This is not easy territory. They're really, really challenging decisions for the executives to make, and we'll be supporting them all the way from a Finance Committee's perspective.
Thank you, Michael. Any comments or questions? No, I know we have, you know, regular Finance Committees where this is discussed in detail. And many of us attend those committees. Okay, thank you. So the board's happy to accept to note the financial position in month 11. Many thanks. Thank you, Hugh. Thank you, Mike. Next item on the agenda is the cleaning standards enhancement. Andrew.
Thank you, Chair. I will assume that people have read the paper, but I'll just say a couple of comments to introduce it. First, I'd like to thank the team for pulling this together, because obviously the request for our response on this came in at a moment when we were under significant operational pressure, so doing this on top of that was no small task. And also in doing so, thank my colleagues Mandy and Hugh, who helped lead on putting this together for me whilst everything was going on, to give me a bit of headspace to deal with the immediate response. I'm very grateful for them helping to pull this together, and therefore when we get to questions they may jump in and help answer some of them as well. In terms of the paper, I suppose it was just to highlight that during the COVID pandemic, the Welsh Government prescribed a new set of standards that every health board in Wales should be applying to ensure the risk of infection was reduced through its environmental cleaning. Although we had undertaken this work, and this has been undertaken initially in response to the pandemic, these standards are set to become the new baseline for cleaning requirements for healthcare environments, and there's different levels to it depending on the different pathways and areas we've got in a hospital. So there are different frequency requirements and levels of standard for green areas, amber areas and red areas as required in response to the pandemic or other there might be different infections in the future as opposed to COVID-19. So the paper has been through Finance Committee in February. We've obviously embarked on a significant recruitment exercise as part of our response to COVID, and did through that recruit a number of domestic staff on fixed term contracts. We're in the process, you'll see in the paper that at the moment we've got quite a significant vacancy factor within the domestic staff group. We are in the process now of working through with all those staff who've taken on fixed term contracts, identifying those that wish to extend their stay with us permanently on a substantive basis, and trying to match those to some of those staff to some of those vacancies, as well as embarking on an additional recruitment campaign to help with the additional staffing requirement that the paper identifies, which is in the region of 113 whole-time equivalent staff with a bill of 2.8 million. There is some suggestion, although we've not had this formally confirmed yet, that there will be some funding made available by Welsh Government to help support the implementation of this, but that hasn't been confirmed through any of the allocation conversation yet. And really, in terms of the paper, we're really looking for approval to implement, subject to receiving that funding. So I think I'll probably pause there, and if there's any questions, we can take questions.
Thank you, Andrew. John.
Thank you, Chair. I welcome the enhanced cleaning standards. I think it's important for the safety of our patients. And we all acknowledge the correlation that exists between the healthcare environment and then the potential for cross-infection. And so these cleaning standards are important to reassure individuals who utilise our services. In terms of the paper, my one question is about the sustainability of our existing approach that's noted within the paper in terms of the staff resource that we've got to deliver these enhanced cleaning standards, and how we're currently approaching that in terms of the fixed term contracts and the vacancies, etc., together with the sickness, and also the potential impact of additional equipment that we may require. So I guess I'm just looking for some board assurance around the proposed model and questioning the sustainability of us ensuring that we meet these new standards and ensure compliance. Thank you.
Yes, I can start, and I can see Mandy's popped on screen, so she may want to add to what I'm about to say as well. But I think the first thing to say is when this review is undertaken, there has historically been an approach, I think, within the team in the way they've managed the resource to run with a certain vacancy factor, which they did fill then through bank use and overtime. So that was a kind of practice that they had. So we've always run with a level of vacancy within the team. So what we're really trying to do through this is change that culture a little bit and move far more to substantiating the workforce and having that as a far more reliable and resilient group of staff that we can draw on in this area. I think there is an element in the paper for equipment as well as staffing, which I think addresses some of the issue on whether it deals with everything. I suppose the one challenge we will then have, or conversation we may need to have as a board, would be if Welsh Government don't come through with the funding, there would obviously be a financial cost pressure to us as an organisation in being able to deliver the staffing requirement to meet the standards as they're set out. I don't know whether Mandy, you want to add anything to that?
If I may, yes. I think one of the there's a couple of key pieces of work that have happened which have led to the development of these standards, and I will declare that As the chair of the Healthcare Associated Infection Delivery Board in NHS Wales, I've actually led this piece of work and driven, I suppose, the standards that we've now got. And we will be doing some further work to look at these not just being COVID additional enhanced cleaning standards, but how we move to a set of standards that sustain and maintain going forward. So I think that's important to note, because as Andrew has indicated, the standards are not going away. One of the things that we've been fortunate, and there's always an upside to most adverse incidents and events, and the pandemic has been no different, is around the technologies that we've been able to introduce within the Health Board already. So the UVA, the UPV, all of the machines and equipment that we've been able to bring in to support our cleaning standards. The other thing as well is the work, and Steve alluded to it earlier, around the work that we've been doing and have started to do around the team around the patient. So there's something about how we ensure that our cleaning workforce, so thinking about the recruitment and the sustainability of them, are recognised as essential members within the care team. And it's a bit like the analogy of the man in NASA, isn't it? And actually they need to see the important value that they make in terms of keeping our patients safe. So all of that work is going on. And certainly part of the cleaning standards is about the level of supervision and training that we provide to them across the organisation, so that we've got a single approach to training, development, and actually they begin to see the value and contribution that they make to us delivering safe care to patients. So I think that working with Lisa's team, working with the domestic supervisors and the new head of service as well, is going to put us in a good place to be able to have a sustainable workforce going forward. Hope that's helpful.
Thank you, Mandy. Hugh.
Chair, thank you. Yes, just to echo a couple of points. Firstly, Andrew did allude to it, but I wanted to be explicit about it, that the recommendation for the board is to approve the allocation of additional resources when approved by Welsh Government. I think given where we are now, there is a significant price tag associated with this, and we haven't included the net impact of that in our financial plan. We've assumed at this stage that there will be funding following through that we need to work through with colleagues in Welsh Government. And of course, just recognising that part of the issue we have here is an aged estate and additional work that we have to undertake to keep that estate clean does come with a heavier burden than maybe organisations with newer estate and premises.
Thank you, John. You've asked a question in this bar about where will this be monitored. Mandy said via IPC steering group through Quasiac, and we could also include it in our performance report. It's one of the most important things that we can do to keep people safe. And I love what Mandy says about, you know, the messages we give to housekeeping staff. They save lives. Yeah. They are absolutely and utterly, you know, a key part of the whole team. And yeah, so thank you for that. Are there any other questions? Okay, the board's happy to accept the recommendation. If for any reason government funding isn't available, can this come back?
It would have to, yeah.
We'll have to make our decisions internally. Yeah. Okay, thank you. Stella said, thank you, Mandy, for clarifying the issue about the team around the patients, as it's important for the cleaning staff to absolutely be part of a team in specific areas, which encourages staff to feel part of a unit and belonging pride. They're integral to high quality patient care. Totally agree, Delith. And you know, you go around the wards, and when they are the constant part of the team, it really does help. Okay, thank you, everybody. We're going now on to the next paper, 3.13, pharmaceutical needs assessment. Over to you, Jo.
Thank you, Chair. I'm just going to say a few words really to introduce this document, which I hope board members will have had the opportunity to read. There is a very large technical document. I know it doesn't open on the iPad, but it does set out the population assessment that has been undertaken in terms of this. And I'd like to thank our public health team, the primary care team and our medicines management team for the enormous amount of work that they've done in terms of putting together what we call our preliminary pharmaceutical needs assessment. This is a new statutory duty that we have to publish a pharmaceutical needs assessment by the 1st of October. And just fundamentally what it means is that traditionally when we have had a new application for a pharmacy to open, we focus largely on the dispensing issue, i.e. the sort of prescriptions issued. And you can see from the summary document that that's an enormous activity in itself, and over 10 million and just under 10 million prescriptions were dispensed by our pharmacies in 1920. But our pharmacies now undertake a lot more in terms of the additional and enhanced services. And what this new regulation means is that when we receive an application going forward, we have to ensure that we look at the needs of our population in terms of any gaps in service that may be there, of the pharmaceutical services that are provided. But if we think we've got a particular need, so we may have, for example, an issue around smoking in a particular part of our population, or obesity, etc., we should be taking that into account in terms of thinking about the sorts of services that we would want any new pharmacy provider to provide. So the legislation is expected to be consulted on in terms of our document. So our SBAR does say that we would be consulting from April, but as we know, with the election now in place, we will be commencing that consultation period from the 7th of May. We have to be out to consult for 60 days, and we expect to bring back to our September board the outcome of that consultation. But we did have an excellent response in the preliminary engagement that we undertook in terms of putting together the consultation document. We'll use all of the usual opportunities through social media, etc., to consult with our population during that time, and we look forward to receiving the responses from our communities in terms of the pharmaceutical needs assessment that we will need to bring back to the board. So it's really just to set out for board members what this actually means for us. It's the first pharmaceutical needs assessment that we're expected to undertake, and we've also linked it into our house style because this is a really important part of our strategy and the opportunity that our pharmaceutical services and through our community pharmacies, the growing services that we provide for our communities. And we talked in earlier parts of the board today about our unscheduled care response and thinking about more that can be done within primary care. This features heavily in that context. And just again, in terms of efficiency, we will be talking about through our regional partnership board about a population needs assessment that we will be needing to undertake. We have to do that every 5 years. We now have a wealth of information that we've had to collate for this purpose that again will stand us in good stead and contribute to that process. So I just want to recommend this to the board today. We do need to sign this preliminary pharmaceutical needs assessment off at the board and agree that we will go out to that formal consultation period starting now on the 7th of May. But again, just wanted to commend this to you and thank the team for the significant amount of work that's been done in getting us to this stage.
Thank you, Jill. We've had a number of comments in the message bar. Donna from the CHC says that the response has been very high from the pharmacies relative to other health boards, which is great. And Ros has also made a comment as well in relation to great context setting with regard to the role that the community pharmacy can play in our communities for prevention and early intervention. And as I think it's particularly important in our rural areas. I'm going to bring in Paul now for a question.
Yeah, thanks, Jill. Obviously this is a long overdue, I think, piece of modernisation in the way in which pharmaceutical applications are dealt with. But with every change there are potential risks, I guess. And I was wondering whether what we've been able to do about highlighting any potential risks as a consequence of this change, and whether we've got any mitigation for those risks.
Sorry, getting stuck with the mute button. In terms of any particular risks, I think the issue is to make sure that we can commission the services that we need to. But we do have 98 community pharmacies within our community currently, and to some health board areas, people would think that we have a lot of community pharmacies there. But I think it's the opportunity to maximise the services that we get from that. I don't foresee any particular risks in terms of the normal sort of competition that we would expect from others in the area where we've seen applications being made previously. Other pharmacies will sometimes indicate that they believe it's a risk if another pharmacy opens in their area. So I haven't foreseen any particular risks at this stage. The only risks would be that we get a poor response around this, but this is something that we would have to refresh. And I think from the pre-engagement phase that we've gone through, we did get a strong response in terms of the early engagement work that we've undertaken.
Thank you. Thanks. So is the board happy to accept the recommendation? And we look forward to seeing the outcomes of the consultation process. Thank you, Diolch. And the next, it's again, Jill, it's the pool funding agreement.
Yes, I don't need to say too much about this except to apologise for an error that is in the papers. This is actually the 2021 agreement that we're bringing to the board at this stage, not the 21-22. It has come quite late in this financial year. It was just missed the January board, but it was deferred as a consequence of the pandemic and the necessary legal advice that we required. So it's bringing it to you for a formality. This is a virtual pooled fund that we have in existence, and that arrangement will continue, but just to signal that we expect to bring the 21-22 report to you at a much earlier stage than in the next financial year, and we're potentially looking as a regional partnership board to make that going forward. But I would just again commend this to you. This is here today for formal sign-off.
Thank you, Jill. Any questions? Okay, the board's happy to approve the recommendation subject to the amendment that it's the on legal agreement 2021. Thank you. And then the next is the funded nursing care. And Jill, that's you.
Yes, again, thank you. Board members are very familiar now with the history of funded nursing care. We've been talking about funded nursing care through our boards since 2012, and people will be aware of the legal challenges that resulted with regard to funded nursing care and the Supreme Court judgment which occurred following the Supreme Court in 2017. What we had agreed previously was a 5-year position in terms of the annual uplift called the inflationary uplift mechanism. There are 2 components that make that up, the labour component and the continence component. We agreed an extension for 2 years following 2019, and the existing agreement is now due to finish. What we had been expecting over the recent year would be that there would be a revision to the FNC statutory policy which is in place, but that work hasn't yet been undertaken by Welsh Government, but we anticipate that that will start in the next financial year. And that delay, plus the impact of the pandemic, and which reduced the opportunity to consider a range of other opportunities or mechanisms that we might use, has resulted in the recommendation that finance leads and complex care leads of health boards recommended to chief executives that we would continue for a further year with the existing inflationary uplift mechanism, which in itself wasn't subject to legal challenge. So we have consulted with a number of groups as a part of this and took the recommendation to chief executives. It is something then that has to be formally signed off by each individual health board as a statutory part of our requirements, and so chief executives supported that recommendation. So it is here for you today to note and hopefully approve as a board that we will continue for a further year with the inflationary uplift mechanism. We will be working with Welsh Government in terms of the review of the FNC policy, the responsibility of which sits with Welsh Government, and we will also use that year then to consider any alternative way that we may revisit this in future years.
Thank you, Jill. Are there any questions on this? Board happy to accept the recommendation? Thank you.
Thank you.
The next, thanks, Jill. The next item on the agenda are the committee update reports. The first one is from Joe, and there is a terms of reference to approving this.
Chair, thank you. So, Chair, thank you. The report covers off the Mental Health Legislation Assurance Committee, the Charitable Funds Committee, Health Professionals Forum, Stakeholder Staff Partnership Forum, and the last update to the committee board. In terms of matters to raise to the board attention, as you rightly said, to ratify the terms of reference, there was also a key risk area from MLAC, just to make board members aware at this stage, which is detailed on page 2 of your SBAR, Chair.
Thank you. Are there any questions on this report? The board happy to approve the terms of reference? Diolch, thank you. Next is the joint committees and collaboratives.
Happy to take any questions.
Any questions on this? Board happy to accept the recommendations? Thank you. The statutory partnerships update. Any questions? Board happy to accept the recommendation. And then for information, we've got the board annual work plan.
Yeah, and just to recognise, Chair, in light of the Chief Exec's comment earlier and the aligning to the committees, that may change as we progress through the year.
Yeah, I'm sure it will. Yeah.
It will.
Shining lights in all those corners. Thank you. Okay, and then the date and time of the next meeting is Thursday, the 27th of May, 2021. I'm now going to go straight into a public trustee meeting, because I think it's really important that the public are able to, for the transparency, to see any decision making that we make as a corporate trustee. And then after the corporate trustee session, I will then close the live session. So any apologies?
No, Chair.
Declarations of interests? Okay, item is to approve the gifts from JC Williams, Elizabeth Williams Endowment Fund to Carmarthenshire County Council for the capital costs relating to the construction of a hydrotherapy pool at the Pentre Arwel village in Llanelli. So over to you, Hugh.
Cadeirydd, diolch. Chair, I don't propose to go into the paper in too much detail because I think the paper is quite clear and speaks for itself. I think the one important point to recognise is the gratitude we have as a board to the gift that was made, a very generous gift and legacy to our community, and I think we ought to recognise that in our minutes. This gives us a fantastic opportunity in Pentre Arwel, but the requirements of the legacy have been quite strict. And quite rightly, and therefore we had a meeting of an administrative committee last week or the week before. Time passes by quite quickly nowadays, where we discussed this very paper and we scrutinised the paper with the recommendation coming then to board or the corporate trustee that we approve the recommendations outlined there, and the which will allow us then to liaise with the trustees and with the bank to release those funds for the charity's use. Thank you.
Thank you. Yeah, Hugh. I'm going to bring in Mike first and then Simon.
Yes, thank you, Chair. Thank you, Hugh, for the paper, very clear. And I've been part of the Charitable Funds Committee, so I've followed and been involved in obviously the story so far. And I echo what you said in terms of thanking the individuals and the families involved for putting us in this very strong position. It's just, I suppose, a question, Chair, around our responsibility as trustees, Hugh, to make sure that these funds are indeed used for the purpose that everybody intends. So the devil is in the detail, I'm afraid, just in terms of receiving an assurance, please, that the funds won't be actually released to the council until either the pool and the facility is completed, or perhaps that we have an undertaking in place that if for any unforeseen reason that the funds can't be used in that way, that they will in fact be returned to the Health Board charity to be used for the original purpose, i.e. for the purpose of benefit for the residents of Carmarthenshire. So just an undertaking in terms of the detail, really, Hugh, as to how and when the funds will be released, and are we expecting the pool to be built first?
Chair, thank you, and thanks for the and I echo the sentiment in terms of the duty of a trustee being an important one in all respects whenever we are handling money which members of the public have kindly donated to us, and with a value with this kind of value, obviously that duty is something we take very seriously, and we will work with as part of that project to make sure that the appropriate governance arrangements are put in place. In terms of the payment and in terms of the payment profile, we'll work on that payment profile and manage that through the Charitable Funds Committee, so that we can be assured that payments are only released on a staged basis as and when we're making progress towards that final build cost.
Thank you,
so
Chair.
We'll have those arrangements in place. Thank you.
Thank you.
Thank you, and thanks for raising that, Mike. Simon.
Yeah, thanks, Chair. I'm glad that the question Mike posed, and also the sort of safeguards and the assurance that was just been given publicly. Just to say, this has come to charitable funds on a number of occasions, and with the caveats that Hugh's just mentioned, I'd like to move the recommendation on page 3.
Okay, thank you. The board, is the trustee happy to approve the recommendation? Thank you. And on behalf of the trustee, can I echo the amazing thanks for the gift that we have been given for the people of Carmarthenshire, in particular people of Llanelli, and perhaps we could have an official thank you letter sent to the fund. Okay, thank you, diolch. So that's the end of our live streaming. Thank you, everybody. If those members of the board could stay behind for a very quick in-committee board, and diolch yn fawr iawn, everybody, and hope you all enjoyed the rest of your day. Thank you.
Can we just leave and reconnect on the in-committee link, Chair?
Okay,
thank you.
So